Greg. Hi, Greg. How are you?
Good, Sandeep. How are you?
Yeah, Salman told me about your new look, and it's pretty nice.
Well, I've had this look for about a year and a half, but I haven't
That
seen it in quite a bit.
yeah, that just shows that we have not met for a long time.
No, that's right. That's right. Yeah, my international travel has gone to about zero right now. I think it's a dangerous place with our current administration for us to be running around the world.
Yep,
So yeah, that's the way it is. How are things with you?
all good.
Good.
So I think we should start now.
Oh, it's 7 o'clock. Yeah. Are you running things today?
I think Salman called me and said that he'll be a bit late, so
Okay.
let's start the session.
Yes, we can start now. So, greetings everyone, and welcome to day two of Young Neurosurgeons Neurotrauma Conference 2025. And we have an exciting lineup arranged today as well. And now let's start with the first session of Young Neurosurgeons session. And I would like to ask Dr. Yusuf Sheikh and Dr. Nida Malik to please unmute themselves and take over the show.
Good morning, good evening, good afternoon. I think we are in a different time zone. I'm not sure is Yusuf around, but just a clarity, my name is Noor, not Nida, but very close.
Yes,
It's okay.
yes, Noor.
Yes, so I think we should start. Our first speaker for today's is Dr. Husni Harman Shia. He's going to talk about targeting aquaporin 4 and melendialdehyde, the role of MLC 901 in motor function recovery after severe chronic phase spinal cord injury in Starets. So just before we start this session, it's the time is really limited. So I would just request the speakers to be quick and sweet, and we are excited to learn from you. Okay, should start.
Okay, thank you very much for the opportunity. Do you see my screen?
We do.
Okay. Good evening from Indonesia, everyone. My name is Husni Harmansyah, neurosurgery resident from Hasanuddin University, Indonesia. Today, I will present my research entitled The Targeting Aquaporin 4 and Malondialdehyde, the role of MLC and 01 in motor function recovery after severe chronic fracture in spinal injury. Why we did this study? Spinal cord injury is destructive, and much of the damage comes not only from the initial trauma, but from the secondary process, like the swelling and oxidative stress. Two key players here are aquaporin 4, which regulated water transport and contributed to the edema, and malondialdehyde, the key of marker oxidative stress, while the MLC 901 is a traditional medicine, with this effect the improve the recovery. Here's the journal published before we start the research. It's explained the potential MLC 901 in traumatic spinal cord injury. And then what we did, we used a rat model with a severe chronic phase spinal cord injury. The animals were divided into three groups: the normal group, laminectomy only, and the negative control, laminectomy and contusio spinal cord injury, and the treatment, laminectomy, spinal cord injury, and oral MLC 901, 7 days. And the aquaporin expression is at level with immunohistochemia, tissue damage with histopathology, and motor function recovery.
So your voice is breaking a
And then
lot.
what we found, the result, rats treated with MLC 901 show much lower expression of the aquaporin 4 expression and MDL levels. It explained the MLC 901 work in water channel and the peroxidability. And on the Tissue damage was clearly mid-rarely in the MLC 901 group, that the glial cell and neuron, it's near around the different, it's negative and normal group. Importantly, the motor recovery was significantly better in short in MLC 901 sim protecting the spinal cord at the molecular and functional level. And the histopathology picture in MLC 901 group, the edema, glial scar, and neuron is smaller than the negative control and the normal group. As explained, the MLC 901 work in reduce the edema and the oxidative stress. And take home message, our study suggests that MLC 901 can reduce the edema, oxidative stress, and diffusion. And then red on 7 days show improvement in the motor function and recovery. And the video will move.
We cannot hear and see your screen. Dr. Hermanshia, if you, yeah, I mean, it's been a while. I was trying to reach out, but I think you were having some trouble with the connection. If you can just come up with your conclusion slide and then we can move on.
Do you see my screen?
No, I mean, I think in the slide. Oh, now we can see you, but
Yeah, I mean, I can disable.
okay, I guess we should move to the next speaker. I would let my co-moderator to please announce for the next speaker, please. Dr. Yusuf, are you around? If you are, you are muted, just in case, to let you know.
Yes, I am here. It's just that the list of speakers is not loading up for me. So
Oh, sure. I can go ahead and announce the second speaker.
yes,
It's Dr. Ashwin Chauhan. He's going to talk about role of steroids in prevention of recurrence of chronic subdural in operated cases, a prospective study. Go ahead, Ashwin. Sorry if I butchered your name. Is it Ashin or? Are you here, Ashin?
Yeah, ma'am.
Oh, sorry.
I'm just trying to share my screen, ma'am.
Please. Okay, we can see your screen. Are you muted or because we cannot hear you? Oh my God, the connection. And you are muted. You are muted. Yeah, please go ahead.
Yeah, it's getting muted again and again.
Can you please share your screen?
we can hear you.
Mm.
She's muted again.
Yeah. Imad, is there any problem with the connection or I'm not sure what's going on?
No, she's doing herself. She's clicking on the the button on the top. That's why it's happening.
Okay, can you just share your screen and then unmute?
Am I audible, ma'am?
Yes, please
Yes,
go ahead.
You are. Okay, great.
Okay. Thank you, ma'am. I'm presenting my paper on the role of steroids in prevention of recurrence of chronic subdural hematoma. The chronic subdural hematomas are common in elderly people with a high recurrence rate of approximately 5 to 30% even after surgery. The inflammation and angiogenesis are implicated factors for the recurrence. Steroids, mainly dexamethasone, may reduce recurrence via its anti-inflammatory effects. The aim of our study was to evaluate the efficacy of post-operative steroids in preventing chronic SDH recurrence after burr surgery. We conducted a prospective randomized control study between January to July 2024, including 84 subjects, out of which 42 were in the steroid group and 42 were control subjects. The surgery performed in all were frontal and parietal burr holes and drainage of the chronic SDH. The steroid protocol which was used was dexamethasone tablets, which was tapered gradually over a time period of 2 weeks. The outcomes were measured based on the recurrence, the neurological recovery, which was judged from modified Rankin score and Glasgow Coma scale, the radiological resolution, and the complications were seen. The results which we found were the recurrence rate was lower in the steroid group at 7.1% as compared to the control group, where 19% of the recurrence was seen. The neurological improvement in the form.
Oh, we cannot. We lost you again. I'm so sorry. You are muted, but you have only 45 seconds left.
The neurological improvements were seen in the form of modified Rankin score, 1.8 improvement in point as compared to the control group, 1.4. The radiological resolution was seen in 92% of the steroid group as compared to 76% of control. Hospital stay was shorter of 4.2 days as compared to 5 days of the control group. And the minor complications were seen in the steroid group, but they were manageable. To conclude, post-operative steroids significantly reduce recurrence of chronic SDH. They improve neurological and radiological outcomes, faster recovery and higher patient satisfaction were seen, and a slightly increased but manageable complications were seen. Thus, to conclude, steroids are effective and safe as an adjunct therapy in chronic subdural hematoma management. Thank you all.
Thank you. Thank you.
Thank you, ma'am.
So are you going to talk about the next speaker, or you still don't have the screen with you?
Please proceed, Dr. Noor.
Okay, thank you. So Adriel Leong is the next speaker, and he or she going to talk about variant and clinical outcomes in a multi-ethnic cohort from Singapore.
Dr. Noor, Dr. Adriel is, I think, not here. Dr. Azadse will present.
Okay. So Azadse, I apologize if I butchered out your name. It's so Azadse Turngu Tetus is going to present the study on diabetes insipidus predictors after pituitary macroadenoma resection. Please make sure you're audible, Azadse.
Can I be seen and heard?
Yeah. Yeah, I can see you. We can see your screen, and it's not being shared on a.
Can you see my document?
Yes.
Can you see it?
Yes.
Can you see my document? Okay. Good morning, my teachers, and good morning, colleagues. My name is Ajate Tengu, and I'm from Memphis Hospital, Enugu, Nigeria. This morning, I'll be making a formal presentation of our paper, which we titled Diabetes.
Can you make it in a presenter mode, please? Can you make it in a presenter mode?
Okay, thank you, ma'am. Can you see?
Yes, that would be much better. Thank you.
So I'll be making a formal presentation of our paper, which is titled Diabetes Insipidus Predictors Post-Pituitary Macroadenoma Resection Surgery. As you all know, diabetes insipidus is a commonly reported complication following a pituitary macroadenoma excision, and its incidence has actually been pegged up between 9 to 54%. The added treatment costs that patients incur, together with derangement in fluid and electrolyte imbalance, has actually led to a development of strategies that to prevent and also to predict diabetes insipidus. Surgery-related and tumor-related and demographic parameters have actually been demonstrated to have a varied ability to predict NDI. Our study was a retrospective study that was carried out in Memphis Hospital between 2006 and 2025 on patients that had a resection of pituitary and macroadenoma in Memphis Hospital. And we're able to retrieve perioperative records that were gotten and are included in demographic, endocrine, anatomical, and operative data of this patient. We're also able to retrieve from our PAC system the brain MRI of this patient, and we're able to diagnose NDI using a set of clinical and laboratory criteria. Categorical and continuous variables were actually analyzed using the chi-square and independent t-square respectively. And we were able to predict the I by assessing the parameters using logistic and regression. From our result, we were able to find out that 56.4% of our patients had diabetes insipidus. And this was about 53 patients out of the 94 patients. And we had patients that had permanent DI was the least, and it was 11.3%. Majority of our patients had transient DI that constituted about 69.8%. Our target population had a skewed preponderance towards a male. The male to female ratio was 2:1. The average age of those who have diabetes insipidus were 35.3 years, and those that did not have diabetes insipidus were 56.4 years. And there was statistical difference between these two age groups. We were able to also find out that the average age of presentation was 42.9 and 43.2 months, respectively, for those with or without NDI. Radiologic apoplexy was noted to be found in 54.3% of our patients, but this did not have any statistical significance. We were also able to find out that the endocrine parameters did not have statistical significance. However, suprasellar extension, recession route were significantly significant in difference in both groups. With the use of a univariate and logistic regression analysis, we were able to predict a younger age group and a suprasellar extension, transcranial approach, and total recession were actually predictable of DI. However, the loss of pituitary bright spot and intracavernous extension were not predictable of DI. Other parameters that were not predictable of DI was patient gender, hyperprolactinemia, hypocortisolemia, and intracavernous and tumor extension. On multivariate analysis, only younger age group were able to predict post-operative NDI. With respect to discussion, we were able to find that our work was similar with the work done by Yasuzuki et al., in which he also reported younger age group to predominantly predict NDI. However, tumor size and suprasellar extension and pituitary bright spots were not predictive of DI. Transcranial approach may reflect the impact of traction and vascular injury to pituitary stalk via the root. In conclusion, postoperative diabetes insipidus in pituitary macroadenoma is predicted by a younger age group of patients and associated with younger age at surgery, suprasellar extension, transcranial approach, and total tumor recession. Thank you.
Thank you.
Thank you.
Yeah, I don't see any question in the chat, but we'll move to the next speaker, Adriel.
I think Dr. Adriel has joined again, I think.
Yes, I think Adriel is here, right? Yes, please go ahead.
Yes.
Okay, hi, good evening, everyone. Just let me share my slides, please.
Go ahead.
Okay. Are you able to see my slides?
Yes, we do.
Okay, perfect. So I'll just get started. So I'm Adriel. I'll be talking about the RNF213PR4810K variant and clinical outcomes in a multi-ethnic cohort from Singapore with Moyamoya disease. So as we all know, Moyamoya disease is a rare cerebrovascular disorder with a catastrophic presentation which has significant disability. The management is typically that of medical or surgical. In terms of the RNF213 gene, the PR4810K variant is a founder variant, which is quite widely seen in Japanese, Korean, and the Chinese populations. Patients have earlier and more severe disease. This gene actually encodes a cyclic E3 ubiquitin ligase, for which the precise pathophysiological role in Moyamoya disease still remains unknown. So the aim of this project was to see if this variant status affects the clinical presentation, radiological manifestations, treatment outcomes, and progressions in a multi-ethnic Moyamoya disease population in Singapore. So our methods, this is a prospective observational cohort study of 46 patients. We recruited symptomatic Moyamoya disease patients from a group of hospitals. We looked at the clinical data as well as a systemic evaluation of imaging markers, both in terms of imaging on admission and subsequently on follow-up. And subsequently, statistical analysis was performed, and we looked at the odds ratio as well as the multivariate analysis. So in terms of our results, the median follow-up was about 705 days. We did see that variants were more frequently observed amongst the Malay ethnic group, and also non-variant status was also associated with that of hyperlipidemia. We found that there was higher familial clustering. A positive family history was seen amongst variant carriers. In terms of our radiological results, we did find that variant carriers actually showed less bilateral disease, and variant carriers actually did show a higher amount of brain atrophy. In terms of subsequent follow-up imaging, there was no significant difference that we did see between disease progression, bilateral disease, as well as brain frailty. This is the univariate analysis actually pointed out the significant factors which we did find, and the multivariate analysis actually did show that Chinese ethnicity remained the only statistically significant variable that was independently associated with carrier status. So in terms of our discussion, we did realize that there is a need for population-specific genetic screening strategies, given that the variant seems to be present across all ethnicities in Singapore. In terms of clinical implications, of note, there was no significant difference in symptom severity, and this actually challenges the previous assumptions about genotype-driven risk stratification. Optimal revascularization is then hence considered to be effective. It should be considered independent of variant status. In terms of our neuroimaging, there was lower prevalence of bilateral disease, and also we did see there was higher brain atrophy. The strengths of this study is that it's the largest prospective genetic analysis of Moyamoya disease in the Southeast Asian population, and it's the first data in several ethnic groups such as the Malay and Indian population. The limitations is that while we are limited in terms of our sample size, it is a limited power to detect more subtle associations while still being appropriate for a rare disease study. And while there is a lack of a standardized protocol, it actually follows the pragmatic nature of real-world clinical cohort. Future directions, we hope to be able to expand clinical endpoints, looking at things, for example, like functional scoring of the mental status. And we also hope to consider systemic cascade genetic screening of at-risk family members. So in conclusion, this is the first comprehensive evaluation of this variant in the multi-ethnic Moyamoya disease cohort. And with the advent of genetic testing, we hope to incorporate it into clinical evaluation and allow for personalized surveillance and care strategies across diverse populations. Thank you very much.
Thank you, Adriel. Strong work.
Any questions from any of the judges or speakers?
No, I don't see any questions, but we can move.
Okay.
Thank you very much. Great
All right.
presentation.
Thank you.
We can move to the next speaker, Seveline Estenia. And the topic is Advanced Technology in Neurosurgery Training for Developing Countries, the Breakthrough and Drawbacks. We can see your screen, Seveline.
Thank you so much, moderators. Good evening, good afternoon, everyone. I'm Sylvian from Indonesia, and I want to share just a 3-minute brief of this theoretical literature review about the advanced technologies in neurosurgery training for developing countries, the breakthrough and the drawbacks. As the introduction, neurosurgery is a field with a demanding surgical skill. We need a lifetime learning, training to achieve proficiency. However, technologies make it possible to achieve this in practical way. But in my country, especially in my center, the fundamental teaching process in neurosurgery is didactic mentorship, with training to the model or cadaver before hands-on to the patient, like see one, do one, teach one method. So we rarely use those advanced technologies such as robotic system, intra-op MRI, navigation system, AR and VR, AI and machine learning. And this leads to variation of experience, successful error, results, errors, even harmful effects among the residents. But in contrast, when we graduated from the neurosurgery, the promotion of those advanced technology are very robust. These are the theoretical literature review with the Science Direct as the database. Using those keywords, we generated 3,382 results, narrowing to 963 articles. So those are the advanced technology utilizations for brain surgery and spine surgery. The key differences are in the brain surgery, the main goal is the functional preservation and real-time tumor lesion visualization. And in spine surgery, mainly for the precision instrumentation, minimally invasive access, and biomechanical stability. So there was a survey by the European Neurosurgery Association, the YNS committee, about the use of advanced technology for pre-op planning in the cranial surgery. With the respondent is the resident and the board certified neurosurgeons, and 23% of them never been trained for those technologies. And the conclusion, the very useful tool for the pre-op planning for the cranial surgery is the software for 3D visualization of DICOM datasets, but simulation tools based on AR, VR, or mixed reality are considered less valuable, less used than other technologies. Those are the benefits and limitations in the brain surgery for the advanced technology. As we can see here, the less expensive is the more need the learning curve and surgical skill like endoscopic skull-base ventricular surgery and awake craniotomy. And it's the same with the spine surgery. The less expensive is the more surgical skill you need to master everything like endoscopic spine surgery and tubular retractor system. And in the spine surgery, those advanced technology are very expensive, and because of the reason to precision and accuracy of the instrumentation, so the promotion of those technologies are very rare. So those are the drawbacks. You have to remember the over-reliance, lower anatomic knowledge, less tactile skill development in robotic surgery if you do it in training, and then the disadvantage of robotic surgery like lack of the sensory feedback. And then there's an ethical issue in AI system like data breach and unauthorized access. So we cannot be discouraged with those technologies because human and technologies can work together. And the role of robotic surgery in the neurological cases by Lin and friends from China, they said still freehand surgeries has the higher accuracy for now, but we have to be open-minded for this robotic system. So we have to remember the ethics in neurosurgery from WFNS in 2011 that we must maintain a high level of professional competence and ensure a high standard of training of the young neurosurgeons. And the conclusion is we think hand-on training is indispensable. It is very paramount. Technologies are adjuvants. The optimal utilization of advanced technologies are good in the trained neurosurgeons and those with sufficient surgical skill to realize the potential harmfulness and the proper usage of the technologies. But in the developing country, yes, it could be applied with the challenges like cost barrier, learning curve, and infrastructure problem. So thank you for the opportunity. Those are my reference.
Very well said, Celine.
Thank you.
Strong work. So the next speaker is Nicholas.
No, he's not here.
He's not here. And there are a couple of people who has sent me direct message that they are part of this presentation, but I'm not sure. I don't see their name. It's Piedad Acurio. She has sent me a direct message, and I'm not too sure that whether it's one of the presenter, but it's not in my schedule. But I think that if not, then this conclude the session. And thank you very much for all the speaker. Thank you, my co-moderator, Dr. Sheikh, and thank you, Professor Sharif and Professor Trost. And I think we should move to the next session. Thank you. Good luck, speakers.
So we still have 10 minutes. Noor, you want to take some questions or discuss any of the topics that were just
Still have
elaborated
time?
here?
Okay.
Yeah, we have 10 minutes.
29. Okay, sure. I think I do have a question for Adriel regarding his Moyamoya talk. He mentioned that in his study he found that patient with this specific trait has some brain atrophy. So do we know that was there any association? Was there any reason that why they had atrophy more compared to the control group? Is he still here or?
Adriel,
Sorry,
please join.
this question addressed to, sorry?
Yeah, I mean, you talked about the Moyamoya, right?
Oh, yes, I did. Yeah. So sorry, I just stepped out for a bit. I missed your question. Sorry.
In one of your I think one of your finding was that the patient with this specific gene or a specific mutation, they had more brain atrophy compared to the control group.
Yes, correct. So sorry, I just have a bit of technical issues at the moment with my laptop. Just give me a second. But we did hypothesize that it had to do possibly with the development of sort of microischemic changes, which overall might affect the overall sort of health of the brain. So because of that, we did see that likely we hypothesized that because of this, due to ischemia of the brain, there might be an earlier sign of brain atrophy in that sense. So even though that they're clinically well,
Yeah.
there is a concern that they may be more prone to getting sort of memory issues, functional issues at a much earlier stage than other sort of patients who might be non-variants. So because of that, we actually did propose to consider sort of earlier screening for such patients in terms of their memory, in terms of their functional status for them. Yeah.
Yeah, I mean but the patient with Moyamoya, they are prone to have brain atrophy. I was just wondering that why this specific, gene would make it more prone to develop. Yeah.
I think we suspect because if we look at the gene itself, we did find that it has sort of pathophysiological roles in angiogenesis as well as vascular remodeling and immune regulation. So I think it's all in because of problems with the perfusion at maybe the microvascular level, and because of that, such patients will then be more sort of vulnerable to getting brain atrophy. Yeah.
Yeah. And then there is another question from Ocean, if she's around. Ocean, are you here? Or I think she's not. Yeah, just I mean, she talked about the role of steroid in prevention of recurrence of chronic subdural. It was a prospective study. So just a question that, do you know that how much dose did you give? Maybe I missed that part in your talk. I think she's not here.
She's here. I've just asked her to unmute.
Oh, can you unmute yourself, Ocean?
She's unmuted.
Okay. So the question is you talked about the role of steroid in prevention of recurrent subdurals. Can you talk about the dose, how much dose did you give, and and have you seen any complications? I don't know, where is she? Oh no. Well,
Ocean, can you please reply to this? Maybe switch on your video if you can. She's co-host, so she should be able to do it.
Yeah.
I don't think so. I don't know.
Well,
Sandeep, what dose would you give steroids?
Yeah, I will not say, I wanted to say that 19% recurrence is way too high. I think there has to be something with the technique, and just using steroid, and even with steroid, it was 9% recurrence. I think we must have done more than 200 and in last 10 years, 7, 8 years, but I don't remember a single recurrence. So I really don't know what is. So people talk about middle meningeal artery embolization also. So in last 1 month, I have seen 2 patients getting a recurrence after getting a minimal MMA embolization elsewhere. So I don't think any of these things are perfect.
So, Dr. Sandeep, do you remove the inner membrane as well when you're doing the
Yes.
chronic subdural?
So we publish our paper in World Neurosurgery. No, we published a paper in World Neurosurgery a few years ago. So we use endoscope in all these patients, and invariably there is always a membrane. And with the endoscope, it is very easy to remove the membrane. So we make a mini craniotomy and then remove the membrane with that.
And do you keep
And by mini craniotomy, you mean about 2 by 2 or 3 by 3 centimeter?
Yeah, 2 by 2. Actually, it's probably 2 by 2 or less than that.
Okay.
And we leave a drain for a day.
Okay. And then what are your thoughts on double burr hole rather than doing a mini cranie? I'm not sure because I've seen people doing 2 burr holes and their results are really, really excellent. One of the paper from Mayo that I recently read that they also have said that, the recurrence rate is really close to, I would say, 0. I mean, maybe they had only 1 case in a couple of years.
I think if your technique is good, recurrence rates will be low. We used to, like, traditionally, tube burrow technique has been done. So throughout my career, I used to do tube burrows. But with that, it's difficult to remove the membrane. So in certain patients where there is a recurrence and you have to remove a membrane, you have to convert into a craniotomy. So now routinely we do a mini craniotomy, and with endoscope we remove the membrane.
Yeah, I mean, you are so right about that MMA angioembolization, and now they're saying that because of the cross supply from the opposite side, so now there are some recommendations that they should do bilateral. So it's too much.
There's no end to it.
Yeah. Well, is there any question from any of the audience or speakers? Because I don't see anything in the chat.
Maybe we ask Greg this question, who has not done one of these for decades.
Subdurals?
Yeah,
No, I did trauma call up until about 6 or 7 years ago.
really.
In my training, I always did 2 burr holes and flushed them out. And I can't remember, maybe it's just my memory, but I have not had a recurrence. I've always been happy with 2 burr holes, but I would say that maybe the issue is that the subdurals that are chronic in other countries may not be picked up as soon as they are here in the United States. And so that may be why Sandeep maybe thinks there's membranes in all of them and they have to be removed, but that hasn't been my experience.
Okay, Omar Farouk wants to say something. Omar, you can unmute. I will
Umar.
just. Yes, Omar, go on.
Can you guys see me? Hi, hi, Greg. How you doing? The beard
Good.
looks nice.
Good, my friend.
I'm digging it. Yeah, I just, I had I think there was a trial, Dex CSDH, as far as I remember, and I thought Dex was out after that because what I remember was there was like 16% serious adverse effects with Dex compared to 7% or something. I mean, I can check that, but I think Dex was out, and in UK, we're not using Dex in chronic subdurals anymore.
That's true. I don't use either, and I'm not sure about Dr. Greg. Do you use sub?
No,
Yeah,
no,
right?
never have.
So
No,
I
I'm
also
30 years
don't
of
use
doing
it.
this.
I use it in only one patient, and because I can't remember what the issue was, he had just underwent a cardiac surgery and he had a subdural hematoma, and for some reason he could not undergo surgery. We gave dexamethasone and his subdural disappeared. It might have been a coincidence also, but that was only one patient's experience.
But I will say too that the literature is really beginning to support middle meningeal artery embolization. So that may be the future.
Yeah, I mean, with MMA, the earlier results were not, they were not that concise, but the latest ones, and they are coming quite a bit now because the radiologists, they are taking up on it, and in a lot of centers over here now, radiologists are pretty keen to do that, but and their recurrence rate is quite low as compared to surgery. But standard over here in England, we're still using drain. Drain works, but one thing that has changed over here in practice in most of the centers that we're not using subdural drains anymore. We use subgaleal drains, and they have less, penetrating the brain, kind of all sorts of those shite. Okay, that's not there anymore, and it works perfectly because you just place the drains subgaleally on top of the hole, and then you just leave it for 24 hours. We're not leaving them for 48 hours like we used to, and nobody is doing those all of those things, keep the patient flat bed rest and this and that has all gone here in England. That's the practice I've been seeing here, to be honest.
Yep, Harshad Parekh from India just said that he's done 500 of these with doing a small craniotomy. And so there are all ways of doing it, and he has had no recurrence. So I think everybody is, as long as you do a good job, it's okay. Do you want to?
No one has zero recurrence. I mean, if someone says
agree.
zero of something, they're lying.
Yeah, Sandeep, you're lying. Sorry.
Pardon?
Greg just said you're lying if you're saying you have no recurrence.
Yeah, if they had a recurrence, if they had gone to another hospital, I don't know,
Yeah,
but I
I
don't
think so.
recall anybody whom we had operated again.
Yeah.
Okay, fine. Do you guys want to wrap up and then we move on?
Yes, I think we just conclude this session, and thank you very much for all the speakers. It's been like a joy to learn from you guys too. And thank you, Dr. Sharif, and thank you, my co-moderator, for giving us this opportunity.
Thank you, No.
Greg, you're the moderator for this
Okay.
session.
Is Dr. Qureshi on?
I don't think he's joined. So Francisco,
Alrighty,
do you want to help him? Yeah,
No, I
Sandeep or
can do this. This
Francisco.
is not
Okay, all right.
this is not some big challenge.
The
So we're
other
going to do
thing
a
is,
controversy session
yeah,
now, and there's 7 topics that are picked.
yeah.
The speakers each get 6 minutes apiece, and I'm sure that Imad will let them know when their time is up. There's been a change in the ordering. The first one will be spine monitoring versus no monitoring with Mirza, and I'm sorry about pronouncing your last name, Pochsik versus Mehmet Zalali, and I think we'll just present in the order that the speakers are listed. So Mirza, you are up first. Please stick to your time.
Yes. Hello, everyone. Can everybody hear me?
Yes.
Okay, thank you for the kind invitation. I'll just share my presentation.
How do you pronounce your last name?
Poiskic.
Poiskic. Yeah, no chance I'm getting it, man.
Don't worry, I have a list of wrongly pronounced versions of my surname. Okay, so thank you for the kind invitation to webinar with many of my friends, mentors, and teachers from WFNS. Without further ado, I will start with controversies in spine surgery, the critical role of neuromonitoring in spine surgery to improve safety and outcomes. A subject which is near to me since at the department where I work, I am one of the people who is responsible for the neuromonitoring. That's also a hot topic in Germany and European neurosurgery. Who is doing the neuromonitoring? You have departments where you have neurologists and specialized technicians who do that, which is, in my opinion, also the best way to do it. And you also have departments where neurosurgeons are doing it, neurosurgical residents and neurosurgeons. So I will try briefly to define neuromonitoring to understand its primary goals, explore its multimodal technique, review the evidence in favor of its routine use, address common counter-arguments, and to provide key takeaways. So what is it? It's actually the real-time assessment of the functional integrity of neural pathways, sensory, motor, and nerves during surgery. It provides actually a continuous neurological exam on an anesthetized patient, and the goal is to provide the surgical team with immediate feedback to prevent iatrogenic or surgery-induced nerve injury. So it detects insults early. It can detect changes, for example, from compression, stretch, or ischemia before they become permanent. So if you're resecting an intramedullary tumor or placing a pedicle screw which landed in the area where you don't want it to land and it caused compression, you can see on the monitoring the beginning of the compression while you insert the pedicle screw, and you can see the very early changes due to ischemia if you have a dissection of the intramedullary tumor in a way which is not good for the patient and for its anatomy. It allows for intervention. You can respond to an alert by correcting the cause, releasing retraction, removing an implant, adjusting a screw, or correcting hypotension. And there is the reversible insult concept. This is the core value proposition and catching a problem in time, which makes it reversible. So this is a scheme of what you can monitor in spine surgery. Neuromonitoring is very big and hot topic in skull-based surgery for monitoring of the cranial nerves, or for brainstem surgery. In the context of spine surgery, we usually monitor motor pathways using transcranial electrical stimulation of the motor cortex for MEPs, or motor evoked potentials, epidural recordings using D-wave, and muscle recordings. Motor evoked potential, you can monitor directly the certain muscles, direct EMG, and somatosensory evoked potential. No single technique is perfect, and you need to use the multiple methods which cover all the possible pathways. SSEP, somatosensory evoked potentials, which monitors the dorsal columns. Sensory pathways for touch, vibration, and proprioception. MEP, motor evoked potential, which monitors the corticospinal tract, and this is often considered the most critical for preventing paralysis. EMG, electromyography, is free-run EMG, which detects irritations to the nerve roots, and triggered EMG to test pedicle screw placements. You have DNEP and D-Wave, which is direct and a real-time assessment of the functional integrity of the corticospinal tract within the spinal cord. There is an old paper from 2007 from the very famous Francesco Sala and Martin Suter group, which has shown that the correction of the patients which profit the most from the intraoperative neuromonitoring. Correction of spinal deformities with scoliosis greater than 45 degrees, correction of congenital spine anomalies, intramedullary and extramedullary tumors, and extensive anterior and posterior decompression in spinal stenosis in spine causing myelopathy and functional disturbance of cauda equina or individual nerve roots. So neuromonitoring is really not needed in every spine surgery. It is not needed for ACDF. It is not needed for simple lumbar discectomy. It is probably not needed for simple T-lifts or simple surgery, but in high-risk patients, and this is what also the guidelines show, is the use of neuromonitoring indispensable. And many scoliosis surgeons would say that it was a major game changer, which enabled them to safely correct or to achieve bigger degrees of correction without fear that the patient is going to be neurologically compromised because they had the neuromonitoring the whole day. This is one of the example how it looks, just for our youngers to see normal and altered motor evoked potentials. This is a great paper on spine deformity, intraoperative neuromonitoring. You can download online and see the most common curves and the most common differences in the neuromonitoring for neuromonitors to see. So it is not all some lines which nobody understands, but you also have a trunkload of scientific literature which have placed a very specific parameters of changes in the waves, which can explain you when is which change relevant and when it says that the patient is going to have a deficit. So the fundamental role of the D wave, if this is with MEP is most important to detect motor deficit, is to distinguish between a transient loss of signal due to surgical irritation and permanent catastrophic injury to the spinal cord. So you have 50% rule, well-established and crucial prognostic guideline. If the D-wave amplitude drops by less than 50% and muscle MEPs are lost, the injury is likely to the gray matter-spinal interneurons. This is a transient injury. So the patient will likely experience a temporary motor deficit, but is expected to make a full recovery. And if the D-wave amplitude drops by more than 50%, it indicates a significant loss of white matter tracts, which is a sign of a severe, likely permanent injury, which alerts the surgeon to immediately take corrective action.
You should move to your conclusions since your time is up.
Okay. There are checklists to the response for intraoperative neuromonitoring in stabilized and in destabilized spine. These are the guidelines which advise use of neuromonitoring in highly selected cases. It, like I said, allows for more aggressive correction in complex deformities. It improves patient outcomes by reducing rate of neurological deficits. It is standard of care in many regions of the world. If you operate on a patient without monitoring and he has a deficit, you have a big legal problem afterwards. It is cost effective by reducing the deficits, and it also gets reimbursed. It has some counter argument says that it has too many false positive, which is causing an unnecessary alarm. False positive is actually a temporary inconvenience, and false negative would be a catastrophic life-altering event. And also some say that method is more predictive of short-term rather than long-term neurological deficits because it tells you it warns you that the deficit is going to be like graver than it is in the long term, which in counter effect leads that you resect less of the tumor or that you achieve less of the correction of scoliosis. But actually, the large studies on use of monitoring have shown that this is not true.
We should stop there out of
is a
fairness
tool
to
for preventing devastating injuries. And thank you. These will be the
Thanks,
most.
Dr. Wojcik. There will be a poll sent out at the end of the session so that people can vote by cell phone. Although I'm sure everybody has their own opinions about these things. The next speaker will be Mehmet Zalali, who must be talking about no monitoring.
Hi.
Hi, Mehmet.
I'm very happy to be with you in this meeting. Do you see my screen?
We see you.
Only me?
Mehmet, you need to make a very strong case for those of the rest of the world where there is no possibility of monitoring. You've got to make a strong case so that we don't
call
feel
that bias, Moody.
and you don't feel pushed into getting monitoring
Exactly.
done. So, go for it, Mehmet.
Yeah.
Moody, we all will vote against it. Don't worry.
Yeah, good. This is my slides. I will say no for monitoring. It doesn't prevent neurologic complications as we are expecting. And first of all, we must know that there are many cases going on. Actually, the number of monitoring cases are increasing from this 300% increase in the United States. Does it prevent neurologic complications? If you look at the types of monitoring, although Mirza has already mentioned, but types of spinal cord lesions are very important. Mainly, there are two types of ischemic. There are two types of lesion: ischemic or mechanic. If it is ischemic, the response to treatment is good, and over distraction, hypotension, these are some reasons. And it is slow, and then a response is very nice. But if it is a mechanical lesion, like you are cutting the spinal cord during surgery, what can be done? Does the monitoring prevent it? No, you cannot. One of the main issues is that the monitoring types, whether it is very slow, fast, or very fast, you cannot get a good response with SEPs than EMG or MEP. The duration, as I said before, if it is very short, monitoring is useless. If it is after certain time, warning of surgeon is possible, or anesthesis is possible, and then you can get benefit of a monitoring. After a long period, like after surgery, you cannot avoid it too much. First of all, we must use such measures. If blood pressure low, elevated, overbleeding, hemoglobin must be replaced. For the implants, remove destructive instruments, make a radiology control, ensure for implants do not compress the dura, and possibly somebody do that. IV bolus metoprolol or wake up test may be possible. What about the limits of monitoring? There are many limits. Actually, there is a secure zone of sensitivity. Otherwise, there are false negative and false positive responses. If it's very sensitive, there are false positive responses, then it prevents you to make your surgery. Likewise, you are removing a tumor, and then it tells you, you are making a hazard to spinal cord. If it is false negative, it's worse than this, because then you are having a feeling of security, but the result is bad. Another thing is SEP or MEP. SEP is not very important because it is the reflection of the dorsal columns. However, MEP is important because we are more for motor function. These are the scenarios, what happens during surgery. If you look at the consequences of these scenarios, if there is no change in potentials and post-op no deficit, this is true negativity. And if there is an incidence like worsened potentials and there is a post-op deficit, this is also true positivity. But in both of these instances, we don't have any benefit from monitoring, because these are the results only showing what happened during surgery. What about this? Worse, potentials worsen, but there is no deficit, like fast positive. This causes you do an improper surgery and causes an anxiety for surgeon. What about this? Fast negativity. There is no incidence during surgery reflected to the waves, but there is a post-op deficit. Worse monitoring. Surgeon will have a wrong safety feeling. The best one is this, probably. There happens some potential worsening, and you are having some measures against this, surgical or anesthetic measures, and potentials improve, and there is no deficits. But how often does it happen? If this is not happening, monitoring is useless. What about the evidence from the literature? This about the spinal cord tumors, most of them are intramedullary tumors. There are also some intradural tumors. There are 109 patients. Monitoring has not improved damage to spinal cord as a result of this study. There are 1 false positive. There are 24 true positive. But the intraoperative measures did not prevent those neurologic deficits. What about deformity surgery? Yes, it is a very common usage, as you know. Intraoperative incidence is 1 out of 42 surgery. Permanent deficits 1 out of 573 surgery. I can skip some slides. From that spinal deformity surgery results, 1% neurologic deficits, 5% alarm incidence, and false positivity is 2.5%. It's very high, actually. They prevent you do a proper deformity surgery. And the alarms are mostly related to the anesthesia, more than 50%. There are case reports in fast negativity with paraplegia after surgery, although the monitoring had no incidence. I will not mention much. Another issue is that preoperative neurologic deficits, if there is severe paraplegia, paralysis, those patients cannot be monitored. You cannot make it. What cases are useful? Deformity surgery, especially cases with severe correction and osteotomies, and intramedullary tumor surgery. And it has a limited value in cases with neurologic deficits. This is a fact.
So
EMG monitoring in
you should move to your
post-screw
conclusion.
insertion is unnecessary. And monitoring in ACDF surgery is unnecessary. Monitoring in CSM surgery, cervical spondylotic myelopathy, is unnecessary. And I will come to the conclusion slide.
Thanks.
This editorial from Neurosurgical Focus in 2017 is saying that it is still not a treatment standard, and not monitoring cannot be accepted as a malpractice. Monitoring can be valuable in neurological high-risk spinal cord patients, but has limits. Maybe we can say in certain conditions, yes, but it has significant limits. It must have indications, and it must be done in good hands. We are sometimes overusing something, like we are doing in each low back patient MR images. It is like this. Thank you for listening to me.
Thanks, Mehmet. There'll be a poll that'll be sent out, I think through email, and people can vote. I think this is a topic that you could spend 45 minutes apiece talking about. So unfortunately, I feel sad for both of you, since you didn't have really the time to go through everything you needed to. Moody, we're going to move back to the top of the list, I think.
All right.
All righty. So that the next one is going to be MIS versus
Nikolai,
open.
or
Is Nikolai here? Nikolai is not yet here, Greg. He did not respond yet.
Okay.
So should we then go over back to Corina?
So Corina will be here in 5 minutes.
We
So
can
maybe
do Dr. Kim, Dr. Abbasi, and Dr. Mehdi. TLF, OLIF, and UB.
okay.
Do we have all those speakers?
Yes.
Kim
All three are here.
And Mehdi is here as well?
Yes.
Okay. So good afternoon, good evening to all of you. I'm joining in from Kenya. And Greg, it's nice to be able to join you in moderating this session. Thank you very much, Salman. So without further ado, we'll call Hyun Sang Kim from Korea. There are three people here, is it? Hamid Abbasi and Mehdi Dermul.
Yeah, three different kinds of surgeries.
Okay, so
they have to sell theirs.
TLIF, OLIF, and UBE. You'll have to explain to me what UBE means, because I'm not familiar with that term, but I suppose while listening to Mehdi, I'll be able to understand that. So over to you, Hyun Sang Kim. Let's hear you talk about TLIF.
Okay, thank you so much, Chairman. Can I share my slide? Okay, can you see my slide here?
Yes.
Okay, thank you so much. Okay, hello everyone. I'm Hyun-Sung Harrison Kim from Harrison Spinal Hospital, Cheongdam, South Korea. This time my topic will be unifocal endoscopic transfemoral lumbar fusion. This is my correct number 10 disclosure. As if we met like this patient, maybe it looks like very difficult cases, and also so many doctors maybe some thinking about that they need some big surgery or some anterior approach. But if doctors and also the patient all that need hope to some more minimized option to this patient, not general anesthesia, not the big open, and because of that, if we can success like this case by the endoscopical, that will be very, very nice to the patient. Actually, the endoscopic transfemoral lumbar fusion by the posterior approach is very easy to the docking the starting point of the lateral border facet. Then you can see the some lateral border facet, and also in the endoscopic lumbar fusion, they have a very, very big advantage of two the distinct advantage. Well, first is that some chronic adhesive disc drilling make a very excellent disc height restoration like this. And the second advantage is that the end plate denudation, that means that the completely preserve the end plate to make a real decreasing so much decreasing the substance and so higher fusion rate. like this. And also, cage also can safely delivered by the using the Harrison cage glider made by me, and also using like this process, you see like this cases also severe collapse cases. You can, in spite of them, using this chronic adhesive disc drilling technique, you can see the result looks like this. Very excellent restoration of disc height without the anterior approach, only the posterior, only endoscopic approach. And also, fortunately, like this result of the scientific result already published by me, so many paper, like you can see here, the using like the chronic adhesive disc drilling, you can see the excellent disc height restoration, excellent restoration of the spondylolisthesis, excellent correction of the focal segment wedging. Because of that, and also currently new instrument cage like this large angle cage, especially 16 and 80 degree and 15 millimeter cage can inserted by the posteriorly like this without the open entry approach. And also in my paper, it already proven that endoscopic lumen interval fusion has a more high fusion speed and more low substance rate compared to the conventional open transfer and lumen interval fusion. I will see some of the cases like this. So severe collapse cases, I already mentioned that using the chronic adhesive disc drilling, this is very easy to restoration without some another additional procedures, only some posterior endoscopic lumen interval fusion. And also like this, then need some degenerative scoliosis correction cases also. You can see the very excellent correction is possible in the endoscope posterior approach. And also, like this case is a very surgery case is also very easily managed by the posterior approach without any additional anterior approach like this. And also you can see like this more difficult cases of degenerative failed back surgery cases. In spite of them, this patient also can take excellent correction only posterior endoscope transforaminal lumbar fusion. And also another cases looks like similar failed back surgery cases also can receive the very excellent correction with the endoscopic lumen interval fusion with under the after sedation anesthesia, no general anesthesia, and also because of that nowadays we can easily can apply to the like this degenerative deformity cases also can pass over like this. Because of that, in conclusion, we first see like these cases, and then using the endoscopic transforaminal lumen interval fusion, you can see like this posterior, immediate posterior OP, and you can see they have only one side decompression. You can make this steroids restored sufficiently, decompression is sufficiently, and this kind of restoration, segmental angle all corrected there completely. And also this all procedures can pass by the no open surgery, no general anesthesia, no suture, no dressing, no transfusion, no infection. Because of that, nowadays, like this serious cases, not that there is no needed another procedures of anterior approach, only it can pass by the posterior endoscopy transforaminal lumen fusion. Thank you for your kind attention.
I
Thank
would
you very
encourage the
much.
speakers, if you have some conflict of interest, like you own or designed a device, that you disclose that in the beginning, please.
Yep.
All right. Thank you very much, Kim, for that masterclass. I think we'll move straight on to Hamid Abbasi from the USA for his talk on OLIF. Please, Hamid, welcome.
Good afternoon. Thank you very much. It's an honor to be with you. And just before I start, I was attending the last part of the last conversation about the neuromonitoring, and I couldn't agree more with that neuromonitoring is a powerful tool. And the relationship to that, to my talk, is that this kind of surgery can only be done with neuromonitoring. Contrary, where probably more than 80% of the spine surgery neuromonitoring is an option. In the surgery I'm going to present to you, neuromonitoring is your eyes, your tool, your instrument that keep you safe. I'm assuming I will be able to share my screen. If you don't mind, I'm going to share my screen with you now.
Please go ahead.
Please tell me if when you are able to see my screen.
Yeah, we can see your screen.
And I'm going to slide my slideshow, and I'm going to keep it very concise. I have developed this as a disclosure. I have developed many of these instruments. I have patent. I have a device company, but the talk has nothing to do with the individual device or instrument. It is it's a talk about the actual surgical approach. So number one is what we need to know is the spine is a very vitally, very frequently performed procedure. Spinal fusion, as a matter of fact, in the United States is one of the highest performed surgeries, period. Worldwide, according to Lancet and other papers, spine is number one for disability. That is important because in the next 10 years, the number of the people who are going to need or benefit from spinal fusion is going to increase. Now, obviously, we don't treat everything with fusion. As a matter of fact, we don't treat everything with surgery anyways. But considering that by the time you're 70 years old, there's only 1 to 2% chance you don't have spine problem, percentually more people are getting to advanced age, more people will have spine problem, and percentually that number of the people who would benefit or need spinal fusion is going to increase. And this surgery that I'm going to present to you, transcamin OLLIF, is a very efficient way to deal with this condition in certain situation. Now, I want you to understand these numbers are staggering in the United States. I'm telling you that because efficiency would become an issue worldwide. It will matter if you can do 1 surgery, 2 surgery, or 7 surgery in one day. That will change really how we practice spinal fusions. And I want to emphasize again and again, MIS, especially my MIS procedure, is not about the skin incision. It's what happens under the skin that makes this surgery efficient. It's not that we do 6 of those surgeries a day. It's about that 2/3 of them are able to go home same day. All the damage you don't cause under the skin is what's important here. All the muscle that you don't detach, and in a regular spine surgery, even in MIS TLIF, we don't reattach those muscles. We don't, in a MIS muscle sparing surgery, we don't disrupt the autoregulation of the muscle. We don't cut the vascular supply to the muscle. Whether I taught a regular TLIF, you would go all the way to the lateral gutter, which we would call it lateral gutter, which is practically transverse process. We would go all the way out, pack it with biologic, and we know we have to detach all the muscle to go there. Vascularization of the bone is through surrounding muscle, and when you do that, you have reduced the vascularization of the bone to the 25% of the original value. And then that we understand that spine doesn't heal fast. That is the reason. We cause a lot of damage to do that. This is my case in 2012, 2-level TLIF, and you see when we go back 6 months later, it's all scar. 2 years later on this patient, I did the adjacent segment OLIF. In 2016, patient had a car accident. I had to take the patient back. That's how I took this picture, where I did minimal invasive muscle sparing transcamin OLIF. It's pristine tissue, no scarring. And that is why this patient do much better after the surgery. So this is MRI. You see what scar look like. We know how a scar look like in real surgical when we go back there, but that's how it looked like in MRI. Here you see the scar, and here you see regular muscle, how it should look like. As a matter of fact, this is a patient of mine after the L4-5 TLIF, 2 level above the multifidus muscle has turned into scar. And these are things that are worth to avoid in your surgery. Now, additionally, efficiency. No surgery is about speed, but this is just a fact. A surgery, if by adding 30 minutes to the time on the anesthesia alone, you are adding 17% to the combined risk of the surgery. So efficiency does matter. If you have any question regarding that, talk to your anesthesiologist. If you put all your surgeries under 2 hours in one group and all your surgeries above 2 hours in a second group, the surgical group with over 2 hours have double the complication rate. In fact, this is based on a meta-analysis of 400,000 patients, and this is everything together. Patients who are prone, that rate is even higher. So obviously, there are many ways of doing the surgery, and I want to make sure everybody understand. I'm not presenting the only way of doing the surgery. I'm just presenting another tool in your toolbox. Each of these surgeries have its own right place to perform. As a matter of fact, this is after 10 years. I think this is my algorithm, how to go about that. I go obviously around the world, I give all these talks and so on, and some people have the misunderstanding that transcamin olive is the only thing I do. Well, there are lots of other experts that do other things much better than I do. That's why I don't go and give a talk about the olive ATP. By the way, olive ATP, if you understand, it's the olive lateral interbody fusion anterior to psoas. But this is the information I'm giving regarding transcamin oblique lateral posterior lumbar interbody fusion, because I have a lot of data regarding that. Now, there are certainly, each surgery is individually different. Each patient has its own priority. If your priority is lordosis, and some patients, it should be younger patient, they have to live 70 years with that, and so on. The best surgery is anterior or oblique lateral posterior anterior to psoas or direct lateral, because you put a ginormous cage in and you correct the lordosis to a level that nothing else can. If your priority is a direct decompression, you have to do traditional TLIF and PLIF. We have done it for so many years. And if you're very good at it as well, you can do it endoscopically or MIS-TLIF. All of that is a possibility. Now, but if your priority is efficiency, I can guarantee you nothing beats the efficiency of transcamin olive. Now, obviously we have published papers. As of yesterday, I have done more than 2,053 cases. And this is the statistic of those cases, that 40% of them you can do under 1 hour. And more than 95% of them you can do, I'm talking about multi-level cases, you can do under 2 hours. And this is not specific to me. As a matter of fact, what's very visible in the data that I have gathered over the last 15 years is everybody who goes through the learning curve is become efficient about 5 to 7 times faster than it took me to get at that level. Like, it took me about 180 to 200 cases to fall under 1 hour for 1 level surgery. Everybody who joins us and goes through those steps and add to our learning curve, they fall under an hour for 1 level fusion in less than 10 to 13 cases. Now, this is, I think, a very important slide, that about 380 cases, 1 year, all the cases, spinal fusion in one hospital. And the TLIF, as you see, is the blue line that literally, as makes sense, the time on the anesthesia, time of the surgery increased with BMI. And every other...
need to expedite your talk a bit.
I will show you only 2 more slides after this. And MIS-TLIF, as you see at the BMI of 37, it becomes even longer and more risky, whereas the OLIF stays in this study and in the next study with the BMI of to 60 BMI, it stays solid. Now, this is the last picture I want to show you, that our patients are ambulating 90 to 96% under 24 hours, and that's why we can send them home, many of them same day. Now, I'm going to stop here. I didn't talk about the technique of the surgery, but there are lots of slides online on YouTube. You can go there, or you can go to Avicenna society.org. There are videos about the technique, how this surgery is done. But if there's any time, I can take some answers. But otherwise, thank you for the opportunity to present this. Thank you very much.
Thank you very much, Hamid Basif. That takes us now to Mehdi Damoud from Tunisia.
Yes, thank you very much.
Nice to see you online.
Nice to see you also, me.
Always a pleasure to have one of our colleagues from North Africa join us. Mehdi, please go ahead.
Thank you very much. Thank you very much. First of all, I would like to thank the organizing committee and especially Professor Salman Sharif and the moderator, Professor Qureshi and Professor Trost. I will share my screen. I will talk about UBE. You see my screen?
Yes, we can see your screen, Mehdi.
I will maybe make it full screen. Okay. UBE is a novel minimal invasive surgery technique which is actually increasingly widely performed due to progressive development of the endoscope and specialized surgical instrument. It shifts the point of visualization away from the surgeon eye or microscope and places it directly at the site of the spine pathology with an endoscope. It allows the visualization of the spinal structure via two small incisions on one side of the spine, minimizing tissue injury and enhancing postoperative recovery. Initially, it was used to treat disc herniation, but actually treat a wide range of spine pathology and even spinal trauma, but it requires specialized training and instrument and a steep learning curve for beginner. Brief history, this technique started since 19 and the endoscopy started since 19, but this technique started 2 decades ago, and Dr. Son from South Korea developed UBE, which was rapidly growing and popularized in many countries now. And why to do UBE? At least we have 4 goals. The first goal to reduce muscle dissection and intraoperative bleeding. The second to reduce postoperative pain and medication consumption. Third goal to reduce operative time and shorten hospital stay. And the last one to lower the risk of infection and faster recovery after surgery with less rehabilitation needed. The indication first, it was indicated for lumbar disc prolapse, but the indication was enlarged actually to lumbar stenosis, to cervical pathology and thoracic pathology, and actually even in spinal trauma. Recent article deal with spine trauma with decompressive surgery in thoracolumbar fracture with stenosis of the canal. Here another article dealing with UBE in thoracolumbar burst fracture with secondary spinal stenosis. The technical principle of this technique, UBE utilizes 2 skin incisions referred further as portal. One portal you make is called the viewing portal and the other is called the working portal. Your non-dominant hand insert an endoscope and your dominant hand uses the endoscope working portal, and we introduce saline with the endoscope to create a working space. And the saline we will separate the different layer, and we can work without any bleeding. This is one of my patients. The patient is positioned in prone position, and we should draw 3 landmarks. One medial line, vertical medial line, and a second landmark medial pedicle line, and another horizontal through the space where we will work it. The position of the patient is prone position, and here we use in the same site the endoscope in the non-dominant hand and another incision for the instrument. And the instrument should be triangulated, and the target is the spino-lamina junction, especially in the inferior border of the lamina of the upper vertebra. And we will, after insertion of the saline, we will create a working space. We work in this space, and then we will drill the inferior edge of the lamina of the upper vertebra, and we can do over the top contralateral decompression in case of canal stenosis through one side. And here one of my patient, after positioning the patient in prone position with watertight drapes, we drew the line, the 3 line, and we should ensure the position of the instrument in the right position by fluoroscopy. And here I show you one of my patient, a 32-year-old male electrician, fall from 2-meter height, causing lumbar trauma, and the patient complaining of low back pain and L5 radicular pain with a visual analog scale of 8, not improved by medical treatment. And you see the plain radiograph, no fracture, but the MRI showed a huge disc prolapse in the L4, L5 space in the right side. We did for him UBE. I show you a small video after entering the instrument here, after exposing the inferior edge of the lamina of L4. We did drilling, and we complete with Kerrison, and we will remove the inner layer of the ligament flavum. You see here the field is very clean, no bleeding, the visualization is good. And we will remove the inner part of the ligamentum flavum to expose the dura, here the dura and the root, and here you see the disc herniation. We will remove this herniation by opening the disc, and by the we'll resect the disc by the rongeur, disc rongeur. And finally, we have a good decompression with a root which is free, no problem. And the patient, this is the incision, small incision, and the patient can walk 3 hours after this procedure without any problem, without pain, no lumbar pain, no radicular pain, and he was discharged the same day. The advantage of this technique, it provides a clear surgical field, as you see, donc you said, donc with good visibility, no surgical range limitation with the endoscope by this technique. You see a small incision, less intraoperative bleeding, short operative time, short postoperative stay, fast postoperative recovery, less postoperative complication, and especially low risk of infection, and early return to work. And also we can have the cost effectiveness of this technique demonstrated by the fast postoperative recovery and early return to work. And this technique do not need the special instrument. We can use the standard instrument of the spine, and no bleeding. The limitation of this technique is the intradural pathology, benign tumor, high-grade listhesis, and also significant dural leak. And the surgeon might have to convert UBE in case of significant dural leak. May have to convert to open surgery, and some author to overcome this problem propose the use of an arm firm which hold the endoscope and to carry out practical intradural work, and to improvise surgical time using both hands for working. This technique need learning curve for UBE be takes time and requires at least to practice 20 to 30 cases. Step by step, the system can make learning curve shorter. There are complications, but less than the open surgery, dural tear, incomplete decompression, infection, etc. We can avoid this complication for the dural tear. We reduce the water pressure and we repair by patch. The epidural hematoma, we should ensure good hemostasis and control the perioperative of the blood pressure. And if there is migrated lumbar disc herniation, we can adjust the position of the incision according to the position of the herniation. We can shorten also the learning curve. We suggest beginner to choose simple at the first time, simple lumbar disc surgery by the left side approach in early phase, which may reduce the difficulty of practicing. They can apply of 0-degree endoscopy in the early phase, which can make beginner adapt to UBE surgery more quickly. And they should start by drilling the bone and keeping the ligament flavum at last. And additionally, standardized training and practicing on model or cadaver are of great help to shorten the learning curve. In conclusion, UB is an innovative surgical technique. It is a powerful surgical method for the treatment of lumbar disc prolapse, but also for other disc disease and also for spinal trauma. It is more clean than microscope. It is a safe technique and effective alternative for treating various spinal conditions because it reduces pain, faster recovery, and with lower risk of complication. It improves the patient's quality of life, and we can consider it actually as an important advance in the field of spine surgery. And thank you for your attention.
Thank you very much, Mehdi, for that excellent talk. If Nikolai has arrived, we can go to Nikolai.
We're supposed to go to Karina and Basant next, talking about future robotic versus human.
Okay, all right.
So Karina Zigarakis from the US and Basant Misra from India will present.
Wonderful.
Karina, if I destroyed your last name.
Thank you so much, Dr. Trost, for having me. Can you hear me?
Yes.
Okay, great. Let me share my slides. Okay, great. Can you see the slides?
Yep.
Wonderful. Okay, so I hear that we have a tight time frame, so I'll do my best. But I've been asked to talk about the future of robotics in spine surgery. So I'm arguing for robots in the use of spine surgery. And I think the main question everyone's going to ask is why should we use robots? So we can capture patients who are seeking less invasive surgery, reduce radiation exposure, be procedurally consistent, and also these robots provide us with great tools for preoperative and intraoperative planning. But what I'm going to say is that I believe that navigation is a critical foundation for robotics. So I should say that this debate should be navigation and/or robotics are superior to just freehand placement and just the human alone, that these are critical tools for us to advance spine surgery further. Navigation guidance enables high accuracy and high precision pedicle screw placement. And the reality is that even in the most experienced of hands, people who've been doing this for decades and placed thousands of screws, bad things can happen, both in the thoracic spine as well as even in the lumbar spine, where actually the most number of medical legal cases in the United States are done for misplaced lumbar pedicle screws, which seem very easy to a surgeon who's been out in practice for a long time. And when you look at the data, it shows consistently across the board that the accuracy of placement of screws increases significantly when you go from the freehand technique to using 2D fluoroscopy to finally 3D navigation. So I would say now we're living in the age of, GPS on all of our phones. Why would you go back to using a compass in order to get around? In one of our own meta-analysis of over 50,000 screws that were placed, CT navigation had the highest accuracy compared to freehand and fluoroscopy. And in particular, robot-assisted screws had the highest accuracy in the thoracic spine. Surgical robots have actually been around for a few decades, even back to before the 2000s when Curtis Dickman used a thoracoscope in spine surgery. We're all familiar with the Da Vinci surgical system, which is used widely outside of neurosurgery with millions of surgeries performed to date, and is becoming the standard of care in many of those fields. Our spine robots have evolved quite considerably over the last 2 decades. Despite this, prior robotic technologies had a lot of limitations, okay? I would say that one of the major things was that they weren't integrated with navigation technologies. And so I'm going to talk a little bit today about the Globus Excelsius robot. I don't have any relationship with this company, except that I was a fellow with Dr. Theodore, and we did the first surgeries in the world using this. So I will share some of the data and that experience. But I think it's really important when we're talking about this robot to mention that it truly is a cobot, okay? So as you'll see here, the surgeon is still the one who is doing everything. And it's really important, and I stress this for all of our trainees, that we still know all of the basics. We still know the anatomy when we're doing these surgeries. So this particular robot has some advantages over prior technologies, including a more rigid end effector. It's mounted to the floor. And most importantly, it integrates with the 3D navigation in real time. And you can do this either with pre-op or intraoperative CT scan registration. This is an example of the intra-op CT workflow. You position and mark for a standard posterior lumbar case. You position and mark the patient. You insert the DRB, which is and the surveillance marker. So you have 2 things to show you where you are relative to the navigation. You place this ICT over the field. You then get a intra-op CT scan, which can be done with many different technologies. And you just need to make sure that you see all of the dots that are on the ICT. You then do a landmark check, remove the ICT, expose the spine. You're able to plan your screw trajectory on a very nice software. Then you bring the robot arm into the field, target the trajectory with a foot pedal. You drill through this rigid end effector and then insert the screw through the end effector. So note that the surgeon is the one who is doing all of this. I was very lucky at this time to be involved in many of these early robotics publications. Our first 5 cases, we showed that we were greatly able to reduce radiation exposure to staff. We showed that we were able to place screws with excellent accuracy, and that we were able to decrease EBL as well as length of stay across the first 26 cases that we did. We also checked what we were looking at, how accurate our trajectories ended up being with regards to the planned versus the actual screw trajectory. And so what did we learn early on from these robotic spine experiences? Robotic screw placement is feasible and safe. Screw accuracy is high, and our planned versus actual screw trajectories are very similar. And OR time is reasonable and continues to improve over time. I think what's really exciting about robotics is that you can use it beyond these open fusions. So there's I showed the pre-op CT workflow very briefly here. I'm sorry, the intra-op CT workflow very briefly here. But the pre-op CT workflow, where you use intra-op fluoroscopy, is even more time efficient. You have a similar workflow for screw placement in MIS cases, and I will say that the robot really is ideal for like an MIS TLIF case. This is one shown by one of my wonderful colleagues in the US, Dr. Snyder. And you can use robotics in complex cases to place screws in unusual trajectories. So here's an example of a transsacral screw that we were able to place using the robot. So navigation and robotic technologies can streamline, accelerate, and improve screw placement. They can decrease cognitive and physical workload for the surgeon, but the setup is particularly extensive for these platforms. So there's a learning curve, and it's important to have a consistent team in the operating room to do this. So in conclusion, I would say that navigation is becoming the gold standard for spine surgery, and that robotics in conjunction with navigation are a powerful emerging tool in spine surgery that are superior to freehand screw placement. Perfect. Current spinal robotics are useful for navigated screw and interbody placement, preoperative planning platforms, both for open and MIS, and the increased competition across many different companies. I mentioned one particular robot that I've used, but these different companies are really accelerating technology development, and future robotic versions will incorporate navigated drilling, decompressions, osteotomies, and rod bending. Thank you so much both to the Hopkins team, where we did this Excelsius work, as well as my team at Stanford.
Well, congratulations. You're the only speaker to be close to on time today.
Awesome.
Which we appreciate. Our next speaker will be Basant Misra, who will talk about surgery done by humans.
Hi, can you hear me?
Yes.
Okay, let me first, kind of say that there is some miscommunication. That was a brilliant talk. I agree completely because I don't know anything about spine. I never do spine, so I have no knowledge about spine, nor in robotic or otherwise. I was told to defend humans versus robots. So that's what I'll do. I just messaged Salman and he said, you go ahead, it's not appropriate because it's not a really debate with Karina. Beautiful talk. I think we should utilize robots more in spine. I agree completely, but I don't do anything. So let me see. I did a lot of reading because this is a talk which is new. I've never given this talk. I was asked to give this talk, so I had to read a lot of the literature to prepare whatever. But I promised Dr. Trost I will finish before time because I don't have much to say. Okay, let me see if I can share. Where do I share? It has gone somewhere.
Usually along the bottom of the screen, there'll be a.
Sorry, you're already sharing.
Am I shared?
Yeah, you were sharing. So just go there and then. Yeah,
you are
just
already sharing, but you are not in a presentation mode. That's all.
Go to slideshow on the top and.
Okay, right. Okay, so my slides you can see, right?
Yes.
Yeah, just go to the slideshow.
No. Okay, fine. So this is what the topic of. This is one of the difficulties of AI, communication gap. We start off with that because this is all on emails, and this is what I got. The future, robot versus humans, and I was supposed to defend humans. Difficult task to do today in 2025. I don't do spine, no conflict of interest, nothing to declare. So this is the robots. I mean, who manufactured the robots? This is humans after all, right? Before I start, I invite you to another legend who is a human. Again, please join us in 2026 in Mumbai. This is the 9th Masin meeting. So robots are, of course, fast, precise, tireless, don't complain, and they can continue, but they're still a tool. They have no imagination, no emotion, no empathy. They cannot feel a massive loss, a heartbreak. Humans have and can. I lost my best friend. I actually operated on my colleague, neurologist. 40 years we have been friends, and he had a GBM. I operated on him, and he died while I was there. And that was very, very painful to me and his family. But sitting with him, I don't think robot can ever, replace a human in that situation along with his wife. So it's important that humans still be there in the picture. Adaptability. Throw a curveball at a robot and it's stuck. Humans improvise, survive, and thrive. Adaptability beats pre-programmed perfection every time. Let me tell you one example. Now you have an aneurysm like this, which is subarachnoid grade 5, is a ICA aneurysm which has bled, and this is the area of bleed. You can see that there. Now standard protocol, now you program it, you put temporary clips, that should be fine to put clips on the aneurysm, and you can open it up because the aneurysm is stuck to the fundus is stuck at the base, and we want to coagulate to release it. And I'll fast forward. This bleeds. And this is where the programming of the robot fails because it doesn't know what to do. And this is when you need to give something which is adenosine. We need to remove the clip because otherwise clips cannot go in. This temporary distal clip we have to remove. We put pack. That's a dangerous thing to do, taking out the temporary clip, but that is the only way we can take care of that clip. And then we do that. So there's just a example where you need to improvise. The standard things do not work. Now, this is another one. This is jugular foramen tumor. Now, the pre-programmed robot will go in and try to remove the tumor, which we try to do it. Now, you see the T2 is a very dark tumor, very firm when we are operating. And there was an injury to the ICA. Now, the robot is programmed to take the tumor out. I mean, he's not programmed. It's not programmed that it will take care of the injury. What it will do, it will sacrifice to control the bleeding. We don't do that. We open up we take out the tumor, we put temporary clips, and we anastomose inside to anastomose of the ICA, which was cut in the cut while taking the tumor out. And we suture with 10 sutures. We achieve so that circulation is preserved. We don't damage the patient. And after we do I think we'll do an ICG here to see that it is intact. I don't know if it's gone or it's still there. Yeah, you see the IC, that the ICA there, suture there. And then post-op, you see that is the tumor removed, that post-op, the medulla and the brainstem, everything is fine. The tumor is removed, there's no problem. Patient is okay. So you have to be adaptive, you have to be creative. Robots follow code, humans follow consigns, create. They produce leaders, they are leadership role, they produce leaders. They comfort when one fails. You don't kind of send him out get another robot. We console him, we counsel him. Inspiration, one can dream of things, and that's how the world is made. So robots, they no fatigue, no mistake, just repeat what is told, but they make big mistakes. I'll give you some examples. Humans, we make mistakes, but that's how we learn, we grow. So the big mistakes, this is a publication, this is BBC, 1992-2017, 42 fatalities in US alone. Some of the famous cases listed in I got it from the literature. 1979, these are the fatalities, 79, 81, as recent as 2023 in South Korea. These are all young people who died during work because of the failure of the robot. Empathy, very, very critical, which the robots cannot have. Robots can mimic emotion, but they don't have empathy. Humans connect, comfort, and communicate. Only humans can empathize. Touching someone, grieving, activates neurochemical cocktails, reduces stress, the cortisol goes down, promotes bonding, oxytocin release, improves mood, serotonin and dopamine release, soothes emotional pain, endorphins and gabapentin. So these are some things I don't know when the robots will produce or they can have it. Yes, robots are cool tools. We need it. But humans create, they empathize, they judge, adapt, dream, innovate, create robots. I see that I'm running out of time. I'm finishing. Humans are the reason, robots are even there. So of course, robots are essential. They're going to be better and safer, but they should and will assist humans. They cannot be independent. But I hope I don't live to see another Frankenstein's monster. So you can do which the robots cannot do. Retreat, introspect, and meditate. Thank you very much.
Great. Thank you, Dr. Misra.
Thank you.
Moody, we're supposed to go next to skull-based tumor.
Right.
Surgery versus gamma knife.
I think, are we going to go to the dural closure?
No, we're going to skull-based tumor, surgery versus gamma knife, Luis Borba from Brazil, and Sandeep.
Okay. All right. Pleasure to see you, Luis.
Imad keeps sending me the update.
You can follow the agenda. I can be to the end, no problem. I was wrong.
So
I was
is
late.
it possible? is it possible to have Francisco, since he has to leave? He has an appointment. I know that his opponent is not there, but we can get Greg to say a few words against Francisco. Yes, please. Is that okay? Greg, you ready for it?
Thank you very much for the invitation. And I share the monitor. One moment that I enlarge. You see the slide?
Yes.
Yes.
Just put a slide.
Yeah. Oh, okay. So thank you very much for this kind invitation and for these controversies. That is open lumbar spine surgery versus minimal invasive surgery. Sorry, if it doesn't. Okay, this is my conflict of interest. Defending the old in face of the new is not easy. So thank you very much, Salman, for this opportunity and this hard talk. But it's important not to confuse what is new with what is better simply because it's new. This is a key point. We have seen in the other presentation regarding minimal invasive surgery in different talks that minimal invasive grants a reduction in approach-related morbidity, a reduction of complication, surgical time, blood loss, and improve of cosmesis. So there is very big expectation in this kind of surgery. But what is the result in this paper? That be careful is was published in 2014. The differences between the lumbar disc herniation treated between open surgery with minimal invasive surgery didn't show very good results, and there is just a lower risk of surgical site infection in favor of minimal invasive. For disc herniation, cervical or lumbar spine, there is 4 cervical trial and 10 in lumbar spine, but there is no significant results respect to the 2 techniques. Sorry. The results change when we analyze the posterior lumbar fusion, and we found that there is a significant less blood loss, there is less back pain in the postoperative days, there is a reduced time to return to work, so there is better short-term results in favor of minimal invasive fusion. But what are the new results? Because as I mentioned, that result was for a paper before 2015. And again, new paper show that minimal invasive TLIF is associated with better VAS, better HODI, and again, there is less blood loss. And this is a very nice paper, very recent from 2024, where really Kim, Sang-Min Park and Young Jong Kim underline that minimally invasive right now is a good option and allow a reduced tissue trauma and faster recovery. The technological advancement, such the intraoperative navigation, robotics we have seen before Corinna's presentation, and augmented reality produce better results for the minimal invasive procedure. And again, the clinical evidence support the efficacy, safety, and the cost effectiveness of minimal invasive respect the open surgery. So, open surgery is really the devil right now, or there is again a role for the open surgery. And if we have to underline this aspect, so we have to consider when MIS is not the best approach, some economic consideration. We know very well this picture from a heart paper, and we know that the MIS benefit zone is between a middle complexity surgery, while the very complex cases have equal or is a little bit better for open surgery. So in case of Cauda-Equina syndrome, multi-level lumbar stenosis, very complex fracture, severe deformity, and infection, maybe the open surgery may have a role just for safety. Regarding the economic consideration, we have seen that from the hospital point of view, minimal invasive seems a very good option, but we have to consider that we have a specific equipment. We need technology like navigation, robotics that have an initial high cost, so we have to consider this aspect. And other things that Mehdi underlined, that there is a long surgical time to obtain a good learning curve, so that it means longer surgery and less proficiency at the beginning. And why? Another thing is that intraoperative complication may need open conversion. It's very it's very difficult to define the rate of conversion in literature because it is mentioned, but there is no results, clear results. And finally, a revision surgery like screw misplacement, junctional pathology, and cage subsidence can be very difficult to treat with minimal invasive, especially at the beginning. In this chapter of book proposed by Mehmet Zileli, they underline the disadvantages of a minimal invasive surgery that are in the steep learning curve, the initial technical equipment, the high costs, and the dosage. But we have to keep in mind that open surgery is an essential step for the learning process because with open spinal surgery we use cadaver lab, we understand better the anatomy, and then we can obtain a good proficiency and move from minimal invasive. And we have to consider also that the navigation and the new technology reduce also the invasiveness of open surgery. So we are moving respect a less invasive surgery. So approaching the spine through a keyhole, we have a partial visualization of the reality of our anatomy, but sometimes it's better to have a panoramic view of the reality. And just to conclude, I think it's essential that the patient and the case selection is a fundamental to choose between a pure minimal invasive surgery, open surgery, or a combine a minimal invasive approach with a mini open approach. Thank you very much for your kind attention.
Great. Thank you.
Nikolai, are you there?
Nikolai is not here.
No, he's not. Like we need to move on with Keenan.
So I won the controversies. The open surgery is better. My opponent is not here.
You say that open surgery is better?
Not at all. Not at all.
Nikolai ran away.
I think that we have a little bit of time for discussion, maybe, but I think the issue is that you really shouldn't do minimally invasive surgery if you can't do it open.
Yeah.
I mean, the rescue for a bad MIS case is opening. I think there's places as you said for both approaches without a doubt. I think one of the things I've noticed in this whole session so far is that people are talking about all these techniques and so forth, but they're not talking about patient outcomes, which is really the important part of all of this. If you're a bad open surgeon, you're going to probably be a worse MIS surgeon.
Yeah, that's true. I completely agree. It's a very hard topic also because to speak only about open surgery or about minimal invasive surgery right now is not actual because every surgeon must know the different technique and adapt the technology and the technique on the correct patient. So the patient selection, I think, is the best way. Probably the very expert surgeon can treat also complex cases in spine surgery with minimal invasive, but the beginning I think is essential to know very well about technique.
And if I may just ask one sentence, as somebody who has built surgical navigation system and has done a dissertation in building those systems, if you cannot do the surgery without navigation and robot, you should not be using them because then you don't know when they fail. Thank you very much.
Right.
Yeah, completely agree.
Okay.
Yep. So we should probably move on then. Now it's going to be skull-based tumor surgery versus gamma knife. Luis Borba from Brazil and Sandeep.
No. Sorry, we go with the dural closure with Marco Fontanelli and Keenan. See, Keenan has to go to airport, so I apologize.
Okay, alright.
Thank you. Okay, Marco Fontanella will talk about plain dural closure, and I expect that Kenan, our friend, will talk about watertight or fat enforced dural closure. Is that right?
Well, yes, I will defend the watertight, and I suppose that Kenan will speak about the other topic. So, can you see my screen?
Yes.
Yes.
Okay. So, watertight closure, and where you can go. Okay. I think we all close the dura because it's about 120 years that Eric Cogin stated this this thing that's an accurate approximation of the dura is paramount for our patients. But of course, there are situations even now during supratentorial procedures, such as bypasses, that the dura is left open or porous. We have to think to three conditions in the head: the supratentorial dural closure, the infratentorial dural closure, and of course the skull-based closure. There are different conditions because of course the skull base is in direct association with the nose and the external, but the supratentorial and the infratentorial dural closure seems to be similar conditions. For supratentorial dural closure, if we like to think if it's better to close the dura or not to close the dura, we have to randomize patients and in two groups, or better in three groups. The first group is when you can perform a primary watertight dura closure. You can approach the two layers of dura and perform the watertight closure. A secondary watertight dural closures, this means when you cannot approximate the dura and then you perform a patch, but a dural, a watertight patch, and what we call an adaptive dural closure, when the dura is not really closed and is not at all watertight. Then you have to decide a follow-up, 1 month, 6 months, and so on. And then you have to study the complication, of course, subcutaneous fluid collection, the CSF leakage, and of course the infections. There are these kind of papers in the literature, and they treated these three groups of patients. And of course, as you see here, the group C has more CSF leak subcutaneously, but the rate of infection and of meningitis are nearly the same. This is a paper published, European paper published in 2008. But we have a meta-analysis that includes 7 studies just published in February in Operative Neurosurgery that try to get information about this patient on the CSF leak. You see this forest plot of CSF leaks in all the 7 patients that where there isn't really a favor or is not significant in favor of watertight closure, but all the papers or mainly the papers seems that the watertight closures is better than not a watertight closure. And for infection, even for infection, we are speaking about supratentorial closure, of course, but for infection, also for infection, the watertight closure is slightly better than not watertight closure, and but this is not significant. And also for meningitis is the same, is slightly better for watertight than not watertight. So watertight closure, we cannot say that is definitely better than not watertight, but all these papers shows that is slightly better. What about infratentorial dural closure? We are very bad in suturing the dura in the posterior fossa. As you see, in 1994, the rate of CSF leak was about 15, 17%, 20%, but it's not better now, 25.6% in this World Neurosurgery paper in 2024. So it's much worse than supratentorial procedures, and there are factors that that induce the leakage, such as the younger age. It's strange that the younger age is in favor of the leakage, but acoustic neurosurgery, neurovascular decompression, infratentorial surgery, longer duration of surgery, and larger cranial bone removal. Of course, there is a difference between operation like Chiari, for example, Chiari malformation midline opening of the posterior fossa, or lateral opening of the posterior fossa, because retrosigmoid approach, because the lateral approach is much more linked with meningitis and with other infections. So Chiari malformation is a revision surgery rate of 3%. Retrosigmoid craniotomy as a leak higher, 7%, with an infection of 1.5%. And what about the skull base? We have to close, it's imperative to close and watertight infection closure of the dura or the defect in skull base is very, very important. And for the pediatric craniotomy is not different from the adult craniotomy. So we are completely in favor of watertight suturing of the dura. Thank you.
All right, great. Then we should move to our next speaker, Kenan Antovic, who will be speaking about non-watertight closure. Or fat enforced, I should say.
Good evening. Can you unshare your presentation,
Yes.
Marco?
That's it.
All right. Can you just please confirm that you hear me and you see my slides?
Yep.
Okay. So my friend Marco did a very, very compelling talk about watertight closure, and I 100% agree. We should always use watertight closure. But just before I start, let me remind everybody what CSF leak complication bring about to our patients, especially pituitary tumor surgery, posterior fossa surgery, as Marco mentioned, and intradural spinal surgery. So this is a long list of complications, and they vary to different statistics, but some of them can be deadly, some of them can increase the length of stay, and some of them can bring about severe debilitation to our patients. So using fat tissue is not new. Many of our predecessors published, like Dr. Mayfield, of course, Dr. Black, Dr. Almefti. So I did not invent the hot water, but I did publish and went on crusade around the world to advocate this, to bring the CSF leak to zero, if possible, or as close to zero as possible, because as you know, one CSF leak is too much. So I advocate use fat grafting in addition to watertight closure to occlude the gaps in dural suture line, to obliterate the dead space created after removal of bone and occlude the dural defects. For example, in intradural spinal surgery, the CSF leak has been reported about 18%. For pituitary tumor surgery, this is a recent publication for multi-center study for continents, 2,826 patients, up to 10%. And then my own article with meta-analysis of Chiari malformation. If you add pseudomoningocele, CSF leak, and meningitis, we are up to 20% of complication related to CSF leak. So this is a very simple procedure that we learned, again, from predecessors such as Dr. Mayfield, Dr. Almefti, to take a small piece of fat tissue at the beginning of surgery. And then we recently published this article, How to Obliterate this Opening After Removal of Pituitary Surgery. And I will just show you a brief example how we do it. This is after removal
of the tumor. And after complete resection, we come to the point of testing the small fat grafting and tailor it size-wise to obliterate the dead space and to occlude the hole. It has to be about 20% larger than the opening. So in that case, when it gets pushed back, it gets stuck into the hole created in the dura. And this is the final product. We do several attempts to measure this graft and then place it in position. And then when Valsalva maneuver kicks in, it gets stuck in the foramen. You can see here the final product, no CSF leak, and then we put additional piece of fat into the sphenoid sinus. With this maneuver, we were able to bring about, in about 200 patients, we had only one case of CSF leak in a patient with 3 times previous surgery. And this was technical error more than technical error on my part, not the technique error, if you will. This is this patient with resection of craniopharyngioma. I'll give you another example. For example, this is patient with a fairly large craniocervical junction schwannoma. I will just go to the resection real quickly to show you that in these cases, we have to open the foramen, wide opening of the dura along the root of the nerve, going out at C2. And once we resect the tumor, obviously you can see here, this is ventral part of the tumor. And once we remove this tumor, which we divided into 2 parts, one was in the spinal canal, the other one was in the foramen. This is part in the foramen that we are resecting. Despite our technique, as I showed in pituitary tumors, in my hands, it is impossible. This is one of the perforators coming off the vertebral artery. It is impossible to close this defect with watertight closure. Why? Because there is a huge gap and there is no really dura laterally in the foramen that can that we can hold with watertight closure. So yes, we use watertight closure the best we can, as you can see here. But then once we finish with patching this graft, there are huge gaps where we don't have dura to suture it to. So we have to use fat tissue and incorporate fat tissue into these sutures and provide the watertight closure with the fat graft. One other thing I want to mention, once we release the CSF in posterior fossa surgery, in spinal surgery, even with Valsalva maneuver, you cannot achieve good pressure, original pressure in the spinal canal or intrathecal compartment, where you can mimic the true pressure, and there are always small gaps that you cannot improve. So I will just finish with this closure of the Chiari-1 malformation with patch graft in a triangular shape. And I can show you just why is it important to put small layer of fat grafts. We remove a large part of bone, like with any craniocervical junction surgery. And by obliterating this dead space, we eliminate the possibility of CSF seeping outside of the dura and then eventually pushing out. So this is also important part of this fat grafting technique, avoidance of dural closure. And in 300 cases of Chiari malformation, I'm still waiting for the first CSF leak using this technique. Thank you very much.
Thanks for your discussion. We should then move on to the next controversy, which should be skull-based tumor, I assume. Surgery versus gamma knife, Luis Borba from Brazil and Sandeep Vishaya from India. So Dr. Borba, you should, hopefully you're here.
I'm here.
Okay, great, thank you.
Okay. I was watching, listening the minimal invasive spine surgery. It's very interesting, but I don't understand. Years ago, when you do a simple disc, you remove the disc, the patient was okay. After came instability. Everybody has instability. Let's screw everybody. Now you are coming to endoscopy. No more instability. You can do everything but instability. Now you can do more and less and less and less. And few people talk about the diagnose, the correct patient. This is what you need to teach to these young people that Sunday evening is watching. Maybe the message should start different way. Let me try to share my presentation here. Oh, sorry. Give me a video. Can you see me?
We can, if you can get your slides to be a
Can you see how?
Perfect.
Yeah.
Yes.
I'll talk about meningioma. That's another thing that is changing, you know. When you are a medical student, you go to the neurosurgery unit and you see a guy that's me, see a guy removing a meningioma. And the guy returned to his life. Or you see somebody clipping arteries. As a medical student, you see, "Well, I want to be a neurosurgeon. I want to spend my time, 5 years resident, 7 years resident, to learn to be a neurosurgeon." When you are a doctor and you try to treat people, you are a doctor to treat people. You receive this guy that's going around my continent, not only my country. This guy was coming overseas. Tracheostomy, gastrostomy, wheelchair. Nobody want to do because this economic situation and clinical situation. And you spend 18 hours in the OR, remove the tumor, and see that the surgical plan that you don't have or don't see in the MRI. Now you can see. And the patient later, after rehabilitation, 3 months, 1 month and a half in the hospital, go back home. We are doctors to do that. Not for machine, not for company, not for money. Meningioma is very confused. Everybody here has a case like that. I'm 100% sure. All the spinalists, the co-hosts, I see a lot of people from around the world, have a patient like that. 67 years old, severe comorbidity, trigeminal pain, medication, 10 years follow-up, the tumor is the same. And the patient has no pain. Every meningioma is a little bit confused. I'm trying to move here. But also, everyone has a patient like this. A patient that come to you in 2017, just diplopia. After pass to several doctors, the doctors say, "Oh, no, not possible. You have a lot of morbidity." Somebody that never did in this case, or never saw, or try and have not training enough. You see this, the planets, the brainstem. 19, the patient come back now with ataxia. and brainstem edema. Now in 20, dysphagia, see. We lost opportunity to try to save the life of this patient with less morbidity. Radiation came years ago to treat patient with meningioma. I remember when I was in Little Rock, 93 to 96, Dr. Omefti, I was saying, San Francisco is the best place in America to work because in 10 years you have a lot of meningioma to treat. But you need to understand that the machine and the indication is very important. We need to believe and trust that it works for some disease. Look at that. Cavernous hemangioma. Guidelines from people from Gamma Knife. Cavernous hemangioma. Very nice surgery. Can preserve the gland, you can preserve everything. But you see, it's work. Look, trigeminal schwannoma. Okay, you can have hypoesthesia dolorosa, but you see, it's work. You see difference, you see different. Look, the meningioma. 90% doesn't change. This is an effect or natural history? This you need to ask. And you cannot leave the business go over us. This is the propaganda. Lexel Gamma Knife in the WFNS meeting. The Americans, as Ken Professor Arnautovic just talked, the Americans, the great Americans. Propaganda here, Gamma Knife. Man, this is to treat with Gamma Knife? They use control. You see, very similar tumor, very short attachment to the tentorium. You can do the surgery and remove like a ball. You can do the surgery in any part of the world. Just need microsurgical technique and good training. The post-op. In genetics now, the people say, oh, the tumor that go after radiation therapy after 4, 5, 10 years, because this guy was a bad guy, this meningioma was not great one, he has bad genetic. It's 2%. See, what you are seeing is different. What you are seeing more and more and more, you get having more and more. Now just come out a paper from Brigham. We are seeing this. You do surgery, you do radiation therapy. The majority of the patients in the world treat radiation therapy for meningioma. It's not radio surgery. It's larger doses and several shots. Radio surgery was one shot. Now it's 2, 3, 4, 5, 6. Radio surgery, I don't know what's going on. What you see this? Have this surgery, remove a little bit, give radiation therapy 4, 5, 10, 15 years later. The tumor come back. The patient meningioma should not die. It's a benign disease. You need to treat benign disease for the people survive and cure, not to control. But this you need training, microsurgical technique, go to the lab, dedication. What you do every day. We are neurosurgeons. Have like this keyhole micro retrosigmoid approach. Oh, very nice session. This year was not my case in there. See, 14, 16, 18. Look, the doses of radiation therapy. 20, anesthesia dolorosa. Man, it's bad. Anesthesia dolorosa. Anesthesia and pain. This patient came to me. I did surgery. I removed the maximum that I could. Not going. I have to go ahead. Oh. 1 year later, back. And now this lady has severe disturbance, cognitive disturbance by radiation therapy, which restored the life of the patient. Radiation induced, everybody knows that the only factor, external factor to treat to the inducement tumor is radiation. You are treating it for radiation. Seeing this more and more radiation you do, you give is relative age, is relative time. 17 years late or 19 years late, death sentence.
So,
if you go to the
Dr.
dentist,
Borba, can you
one
start
second, just 1 second. I'll
your
finish 1 second.
conclusions? Thank you.
Yeah, I'm waiting 2 hours here. Okay.
Well,
yes, let me just finish here. I have to give this message very important to the people. So go to the dentist. Very dose radiation therapy, much more incidence of this. Just go to the left side.
thank you.
We are talking too much about technology. You're forgetting people. You forget patients. You forget that they need to do. Today, and go to the conclusion, okay?
Thank you. I'm trying to be respectful of everybody's time.
Okay, no, everybody pass the time. I think we'll be okay. This is just treat the patient, not image. Be more doctor and means and less technician. Thank you very much.
Thanks, Dr. Borba. Sandeep, you are up next.
Sandeep, go
Can you
defend
see
it.
my
Let's see.
slides? Can you see my slides?
Yes.
Okay. So excellent talk, Dr. Borba. I completely agree with you. We should look
I
at the
couldn't talk.
patient. Yeah.
It's
So
okay. It's okay. Okay. I go home.
What I'm trying to say is that gamma knife is not a competitor of surgery. So there is no debate here. But what I'm trying to say here is there is a definite role of gamma knife in certain group of patients. As surgeons, we tend to, our thought is that surgery is always the best option. But in certain cases, certain instances, it may not be possible. In some cases, the tumors may be, you may be an excellent surgeon, but everybody may not be. It is correct that everybody should get a perfect training. But some people may have limitations in their centers because of various reasons. So instead of trying to remove every last bit of tumor and damaging the patient, there is always a role of leaving a little bit of critical tumor behind in critical area, which can be very well tackled by gamma knife. So gamma knife, firstly, is not a substitute for surgery. If the tumor is large, then surgery is perhaps the first and only option. Like this, I am just showing tumors I operated last month. So of course, this needs surgery. And radiosurgery is definitely not a substitute for bad surgery. This was an acoustic, bilateral acoustic, operated somewhere else, referred to me for gamma knife. You see that only a little bit of tumors was removed. And so I convinced the patient that surgery is a better option. We operated him, small residual disease, and then we treated him by gamma knife. Again, there's another patient, 64-year-old lady, operated in another country. You can see only a little bit of tumor was removed, bilateral frontal lobe have been removed, and the patient came in that condition. So we operated and removed the tumor. Again, petroclival meningiomas, as you showed, they are the more challenging tumors. This tumor I operated, I think, last year, and complete tumor excision. There's no need of radiosurgery. Another patient I operated recently, he was a chef by profession, presented with incoordination of movements and had difficulty in cooking. So we operated him. Again, there's no role of gamma knife here. But again, this patient I operated last week. Again, all these large tumors, they do need surgery. But if you see the published literature, particularly in petroclival meningiomas, the morbidity is high. And so this paper published by Yang in 2011, 68% patients had cranial deficits. Here, all the top guys from the world, Yasargil, Mayberg, Al-Mafti, Sami, Spetzel, Bricolo, Caldwell, and et al. And you see the gross total resection rate was ranging from 20 to 80%. And cranial nerve deficit average was about 50%. Bricolo had the maximum resection rate around at 79% gross total resection, but had also the maximum cranial nerve deficit at 76%. So one has to look at the patient's morbidity also. This was a paper published 2018, petroclival meningiomas after primary treatment with gamma knife. It had a good tumor control rate at 98% at 5 years and 93% at 7 years. That's a pretty good preservation and without significant morbidity. Again, this was a primary versus postoperative gamma knife, and they had similar results in both. So this was another giant temporal meningioma that we had operated, and there was some disease left in cavernous sinus treated with gamma knife. Patient is doing fine. Again, this patient presented with mild ataxia. Of course, one can remove with surgery. Sometimes you have to cater to the patient's wishes also. Many patients don't want a big surgery, and along with the morbidity that it can cause, and when it can be tackled with gamma knife. I have been doing gamma knife for last 28 years now, 29 years, and results have been fantastic. You have to choose your patients carefully. Again, the only symptom, mild hearing loss. This patient presented with complete loss of vision for 1 month, most likely an atypical meningioma. Tumor is going into the orbit. We treated by gamma knife. It's been 6 months since then. Tumor is stable. Again, a petroclival meningioma had operated. There is a small residual disease, so we treated it by gamma knife. So this was a giant cavernous sinus meningioma. I encountered some bleeding, I presume, from ICA, and the patient developed a pseudoaneurysm after surgery, which was coiled. And then that's why we had to stop surgery at that time, and this was followed by gamma knife to control the disease. And it's been 1 year since gamma knife, and the patient is doing pretty well. The disease is well under control. As you rightly said, most of the patients won't reduce in size, but they won't increase either. So the patients continue to live a normal life. And this was again, this was a doctor who was treated at 27 years of age by gamma knife at another center. And that was 2004. He remained stable. He presented with 6 paresis, which improved after gamma knife. These type of tumors you can hardly remove completely, so as to say. And then we treated him again because he showed a slight increase in the size of the tumor 20 years later. Again, these are small tumors that we treated. I would really like to avoid major surgery for such small patient presented with 6 paresis only. So this was a very large tumor. My fingers were itching to remove it. But when we sent him for pre-anesthesia checkup, we found his ejection fraction was 20%. He has RBB, had a congenital heart disease, and very high PE pressures. Anesthetists absolutely refused to give anesthesia. And its volume was pretty big. So I've never treated such big tumor before, but we fractionated the treatment, and let's see how it does. It's been only 3 months. Again, people say that chordomas are pretty radio-resistant. This was a patient who came to us about a year ago, operated elsewhere. There was a slight increase in this disease. We treated by gamma knife, and you can see this is just a month ago, and the disease is significantly smaller. Again, tentorial meningioma. And so these are all examples of tentorial meningioma, small tentorial meningioma, small cavernous sinus meningioma. Again, small cavernous sinus meningioma. So I wouldn't really go for a big surgery for such small tumors. This was a patient of juvenile nasopharyngeal angiofibroma. It was extremely vascular, operated by ENT surgeon twice over 2 months after tumor embolization. And yet this much disease was left. And we treated by gamma knife, and this was 7 months after gamma knife. The disease is significantly smaller. So in meningiomas, again, in many patients, the disease do decrease. These images were loaned to me by a friend. So you can see progressive reduction in the size of the tumor. So to conclude, gamma knife is an excellent alternative to treat small skull-based meningiomas. Tumors which are in areas which are difficult to access can be easily treated without significant morbidity. Residual tumors can be easily treated by gamma knife. And though in surgery, the aim should be to remove the tumor completely, but in difficult cases, instead of being over-aggressive, one can leave some tumor behind and treat it by gamma knife later. It can be a rescue procedure in large tumors occasionally when surgery is contraindicated due to medical reasons, as in the example I showed. Thank you.
Thank you very much. I think that was an excellent debate or discussion regarding the tumor excision by Luis Borba and the very rational approach that Sandeep has taken to use surgery when it is appropriate and not necessarily go for surgery every time. If there are appropriate patients, whether medically or otherwise, one would then opt for gamma knife. Thank you very much, Sandeep. I understand for that our last session, Professor Bin Su is not has not arrived in the panel, so I think we'll leave it to Azam Ahmed to entertain us with all manner of
May I say something?
discussion. Yes, please go ahead, Luis.
You cannot leave the impression that you should remove at all costs. I'll not say that. We should say that the only curative treatment is the removal. And for this, you need to try and to need to train, you need specialty. Does not mean that you go and hurt the patient. See, it has to be very, very clear. When you talk about today about removal of tumor, looks like you are saying, oh, you are destroying the guy, you're leaving the guy completely. It's not that. We as neurosurgeons need to train, need to prepare, need to be educated to do what is best for the patient. And you all know that the best way to treat meningioma is a total removal, but does not mean that you can get in every case. It's very common you leave some piece, a small piece, and the patient stays his entire life with a small piece of tumor without any complication, without any growth. This is very important to be seen. You cannot give this impression that you are doing surgery to clean the MRI for our ego. We're not doing that. We're doing that we believe with our training, our education, when everyone can do, and everyone must do. Train, and learn, and do the best for the patient that you all know. Just to give this, sorry to tell that. Sorry.
Thank you. Thank you very much, Luis. So, Azam, are you ready to share your screen? I think you're the only speaker in this part. We'll just go ahead. Thank you.
Can you see my slides?
Yes, go ahead.
Well, thank you very much for this opportunity. I wish he was here, but I don't think it's much of a debate. I think that both have their place, of course, in the treatment of aneurysms, and I'll change it from coiling and clipping to endovascular treatment versus cerebral vascular surgery. Initially, when I was training, endovascular was early on was kind of newer. The reason why I went into vascular neurosurgery was not for the endovascular side, but for the open vascular surgery to do things like this. Seeing the future, we all knew that it was going to go towards endovascular. At least that was an important, it would be an important adjunct to training. And so I got that training in endovascular. It was always a question, can you do both? Should you do both? At that time, that was a debate. I think that debate has really been settled as to, regardless of what you think the big fish is, it's certainly, there's a generation of neurosurgeons my age and younger who certainly, I think, can do both. But a decision for which way to proceed with the patient is really based on the patient population, with a lot of great work being done on ruptured patients. And the location also plays a significant factor, anterior versus posterior circulation, with specific locations having different consequences. Basilar apex going in favor of endovascular, and MCA bifurcation continues to be an area where There are ongoing soirees from different endovascular techniques, which have continued to be sort of fraught with peril, and I think really do not meet the bar for treatment and beating the natural history with open surgery or with endovascular treatment for that location. A very significant component is patient preference in this era of shared decision making. That is something that is very, very important, and that has its pros and cons. And then technological advancements, as we all know, is really is a main driver in these decisions and what the opportunities are for patients. Most importantly, the comfort level of the surgeon. I think this is the lens through which we advise the patient, and that's really where the comfort level of the surgeon should be really on both sides. If a surgeon can only do one thing, endovascular, so they should have a good open surgical partner. And that is something that I think really, unfortunately, is going by the wayside for what people see as a settled debate, as that in all locations, for all patients, in all situations, that endovascular is better, and that's really not the case. So if we go with the ruptured aneurysms, this has been, I think, we have the best data for this with the ISAT trial with Andy Molyneux and colleagues in Europe, and some in the United States, showing that absolute risk reduction was 7.4%. In the Barrow ruptured aneurysm trial in the US, we have a absolute reduction with endovascular treatment for these ruptured patients of 15.5% in the actual treatment arm. There was noted a high crossover from clip to coil of 37%. So that's notable because, over 1/3 of patients were initially deemed to be suitable for both treatments. And then ultimately it was decided at some point prior to their actual treatment that, hey, in fact, we cannot treat this endovascularly, and they should instead be treated with surgery. That patient cohort did not fare worse than the patients who were initially assigned for clipping. They fared about the same, which was overall, quote unquote, worse than what the endovascular patient's outcome was. In that third of patients, however, there was not truly equipoise, and that they sort of failed endovascular treatment. So this trial, in my opinion, having trained there, of course, done by great people, Dr. Spetzler and McDougall in Albuquerque, with whom I did fellowships, I'd say that this is the best cohort in the world to do this surgery. And these are the results, which basically say if you can treat it endovascularly, the patients would fare better. But if you cannot, then clipping, of course, is a great alternative. There's a lot made about late rebleeding on the open surgery side. And if we look at the complete occlusion rates on the left-hand side here, they were much lower in the endovascular treated group, only 66% achieving complete occlusion. And in the microsurgery group, 82% of those achieved complete occlusion. However, if we look at the likelihood of those patients having rebleeding during their first year, they were really quite similar. This durability was published in the almost 18-year follow-up of the ISAT trial, showing that patients who were treated endovascularly had a lower death and dependency rate with endovascular treatment, and independence was similar but lower in the endovascular group. The overall risk reduction, importantly in ISAT, was 7%, not 77%. And this really changed how things were done, despite a very small difference in the absolute risk reduction. If we look at the rebleed and this long follow-up, there were more rebleeds on the endovascular side, but not by a large number, by a few patients, and that rebleeding was not statistically significant between the groups. In the unruptured aneurysm clipping side, if we look at those patients and their long-term follow-up, this is a well-done study which looked at meta-analysis and looked at morbidity and mortality. And what you can see here is a very low mortality with clipping, very low morbidity with clipping. However, if you look at these funnel plots of mortality and morbidity, you can see these asymmetry at the base here with the standard errors indicating significant bias in these publications favoring better outcomes. So it really hampered on the open surgery side with bias in how these results are reported, and that's unfortunate. If we look at the follow-up ISAT-2 prospective study, it was powered for, and this compared open surgery versus endovascular treatment. It would have been a very important study. However, it was powered for 260 patients after a very slow accrual, which was tapering off. Only 136 patients were actually ended up being randomized and treated. So there was no significant difference in morbidity at 1 year. Since my colleague is not here, I will just continue proceeding for another 5 minutes or so, if that's okay, if the moderators.
Yeah, that should be fine.
Okay, thank you. So if we look at endovascular unruptured aneurysm treatments, there's coiling, and this is a moving target in that the coils and the endovascular techniques continue to evolve given the significant infusion of not only manpower and energy, but also the industry, highly patentable devices. We can look at primary coiling trials on the top here, or registries, stenting with balloon-assisted coiling. You can see that sometimes the complication rates are quite high, 10.3% versus 9.3%, and this is for stenting 10.3 and balloon-assisted coiling 9.3%. And much of this morbidity is due to middle cerebral artery aneurysm coiling, middle cerebral artery aneurysm coiling. This is an area where we've known for a long time that MCA aneurysms have a much higher risk of treatment with endovascular techniques. However, people continue to push on, which is very, very frustrating to see. Unfortunately, the all or none sort of a treatment paradigm. The PUFS trial, a pipeline device, really was a game changer. And if you look at the 3% occlusion rate for patients who were not candidates for other endovascular treatment paradigms, there's a very high over 93% occlusion rate. And some of those 5 patients required retreatment, only 0 recanalized. Some of these patients certainly were candidates for open surgery, but this is certainly a very powerful technique for certain patients. Now we have various intrasaccular occlusion devices like the Webb device, demonstrating low complete occlusion rates. 84.6% were deemed adequately occluded, and importantly, the hemorrhage rate still, however, is quite low. So I think that is the important point here, is that the retreatments do not carry this significant morbidity that has been sort of oftentimes overstated. However, with endovascular, importantly, even despite the paradigm shift, there are still issues. This is a patient who came in with standard subarachnoid hemorrhage, has an aneurysm, A1 segment, kind of an unusual location, middle of the A1, no contralateral A1. This is treated endovascular, as you can see here, with still some filling in the dome, but due to the wide neck, was not pushed further. Within 6 months, the patient presented, unfortunately, with progressive visual loss, which we evaluated with MRI. And you can see here that the patient has significant compression from this thrombosed aneurysm, with the coils being pushed way up and recurrence at the base. Despite attempts to be able to clip this patient, the family and the wife were quite scared of this. Again, that shared decision-making coming to bear, and therefore we treated this with the Elvis stent and recoiling, and we'll see how he does, but that would not have been my preference. But I did not have the option, given that the family would not allow me to treat them open surgically. So do additional treatments for recanalized aneurysms increase lifetime risk significantly? I think we have these one-off cases. However, if we look at larger series, this one from France, they would say that in 4 centers, a lot of patients, a lot of 20,000 of patient years, 28 rehemorrhaged in that time, so a very small number, less than a little more than 0.5%, and many more were retreated without rehemorrhage, almost 5%. So the morbidity of that retreatment tends to be quite low, and therefore this philosophy of endovascular retreatment being a very concerning thing is, I think, really overstated. It's similar to this, where you have to first pass that initial hurdle of treating the patient with their initial problem. And if you focus on the second gate here, you might stumble on the first decision, which would be the higher risk treatment potentially. Here's another patient, which I think highlights the importance of combined techniques. Is a patient who came in with this aneurysm, which is a sidewall aneurysm coming off the carotid at the communicating segment here, and also an ophthalmic segment aneurysm. Initially, this patient, due to her young age, was treated with clipping, as you can see here, with, I think, a good result. However, within 1 year, she pooched out these new aneurysms, ICA terminus, A1 segment that you can see here, and just distal to the clip. So it's really quite surprising to happen within 1 year. We do not have a solution for this with open surgery. This is really where reconstructive techniques with flow diverters, after clipping, you can see a flow diverter in the A1 segment here, followed by another flow diverter jailing off the A1 segment in order to achieve a good reconstruction with an intact patient. So really, the other very important point here is, what do patients want? Despite attempts at trying to guide patients gently but sternly towards a certain treatment, they may choose one way or the other that we think may have a slightly higher risk, maybe not unacceptably high, but higher than we would like. And that happens both ways. Here in the Midwest, we have farmers who say, I want to get my aneurysm treated, never have to worry about it again. They want it to be clipped. And the younger patients are potentially more risk averse, and they equate that risk of treatment with recovery time. And so therefore they may opt for, or really push hard for, an endovascular technique. However, ultimately, I think that this ship has sailed on this conversation of which one is better. Really, there's important drivers, and there's been a paradigm shift. If we look at what is being done now in the US, and overall, about 2/3 of aneurysms are now being treated endovascularly, only 1/3 being treated with open surgery. And this is a National Inpatient Sample database. If you look at the Helsinki experience, it's even more dramatic, 70% at a center, very skilled operators, 70% being treated now endovascularly. Really, I think that it's shifted to a point where now we have expert groups for open microsurgery to lend their expertise and try to continue to do this. So really, innovation has really fueled the push for newer endovascular devices, robotics, AI. All of this will continue to push endovascular techniques further and further. And we can see all these new devices that are coming out. These are not theoretical devices in the top left, but those that exist currently. In addition to flow diverters, AI techniques showing us how well opposed devices are, and better understanding of antiplatelet agents for these devices, and soon to be robotics for endovascular, which will allow endovascular specialists to really extend their reach much further than was historically thought. So the pendulum has swung perhaps too far, depending on who you believe and who you follow. However, I'd like to see that patients be treated appropriately, and that people have honesty with regards to the risks of treatment. Middle cerebral, and based on this analysis of recanalization of endovascular treatment, we can see patients who are higher risk for endovascular treatment: those who smoke, those with ruptured aneurysms, larger size, wider neck, middle cerebral artery location. All of these are also potential risk factors for open surgery as well. So I think our primary focus should be on safety, the safety for the patient, not for the proceduralist. Really, if the skills are not present in one person, then they should work with a skilled colleague and be honest and forthright regarding the best way of treating that patient, which is the lowest risk option. Not just what can I do, what do I have available in my skill set, but what should be done for the patient. A recovery time is a secondary consideration. What is a couple of weeks or a month in the life of a patient, exposing them to a higher risk treatment is, I think, inappropriate. So ruptured aneurysm are better treated overall endovascular as a first step, a default. However, many patients will not be amenable to that form of treatment, and therefore we have to maintain our open surgical skills in order to be able to offer that to patients. And there's site-specific considerations and wishes of the patient should be primarily considered when there's equipoise for treatment. So with that, I'll conclude. I don't really think it's much of a debate between the two. I think really these have their own place in therapy. And despite newer techniques and all the infusion of energy from industry and money that's involved, I think there will continue to be a place for both if we're honest with our results. And if we even look at the published data, we can see that if a microsurgeon published 10% complication rates for their techniques, they would be laughed off the stage. However, that's allowed in endovascular arenas because of in my opinion, the money that's involved in this. So with that, I'll conclude and thank you for your attention.
Thank you
Thanks,
very much.
Azam.
Thank you very much. There's been one question that's been posed, and that's about your thoughts on the best timing for intervention, whether it's surgical, particularly surgical, but also for coiling. What's your thoughts on that? And I think that there are people on the webinar who are keen to know your thoughts on the timing of these interventions.
May I ask something? Me?
Yes.
There is one point that what's happened with the patients that you are treated in the past with coil, with matrix, is coming every day a new device. See? And you believe the web, for example, the web that now is advertising around the world how the solution to everything. They have 52% of complete occlusion. Should be not out of the marketing? Because if you have an aneurysm, just 53% is occlude. It means the aneurysm is still open. You are going back to the natural history or unruptured aneurysm.
Yeah,
90% is 100%.
Yeah, so with regards to the first question regarding the timing of surgery, I think for ruptured aneurysms, that is, quite well settled, that the patient should be treated ideally early to prevent rebleeding. Rebleeding rates are up to 50% at 1 month, depending on the case series that's followed or the data that you look at. There's various ways of looking at that. Obviously, prospectively, retrospectively, have good data on that. The technique of treatment, I think, has to be able to meet the patient where the demand is. So if we know that patients rebleed if they're not treated, if they present with hemorrhage initially, and so treating those patients, whether it's with endovascular techniques or open surgery, the aneurysm needs to be secured. And to Dr. Borba's point, I think that occlusion should be something that allows the patient to prevent bleeding. Now, when we look at aneurysm occlusion rates, obviously complete occlusion is a great goal, but really what we're trying to prevent is rebleeding. In some cases, incomplete occlusion endovascularly, as many of the series show, do not result in rebleeding. So the fist pounding of, well, the aneurysm is not completely occluded, the large series would not indicate that is problematic over the short term. Okay, I'm making a distinction here. This is not something that the patient should live with for their life. If that patient if we go in and we put one small coil in a large aneurysm, that does nothing to help the patient. We'd all agree with that, probably does very little. On the flip side, putting in many coils, achieving a packing density that's over 30% with a little bit of residual filling in the aneurysm at the conclusion of the case, I would argue is an adequate result at that time. And most often goes on to completely occlude. That is not the intent when the patient is initially treated endovascularly, but that sometimes is the result, and there's a trade-off with that. Now, I feel like I'm pretty balanced. I treat 50% of patients endovascularly, approximately in my series, and I treat 50% of patients with open surgery. And I think that that allows for an appropriate balance of the two procedures and to treat the patient in the appropriate context.
Can I make a comment, please?
No, but I'll ask you something. If you have a device that occludes 53% of the aneurysm, it's good?
No, I don't think that that's good.
Why is it still in the marketing?
I think that there's two different scenarios. One is that you've put a device in the dome where we all know the aneurysm ruptures from is still filling. It's still filling aggressively. You can see that. That is one scenario. The other scenario is an aneurysm that is, like, again, packed to over 30% packing density, where there is some filling in the dome, still a Raymond 3, right? But that is a very different situation. So with regards to the web device, the filling in the dome of those patients, many of those will go on to completely occlude, leaving patients, and I think that without and that experience took time to develop. I'm not a great proponent of web. I've put in many of those, but I'm not a big proponent of it for a number of other reasons. But I don't think that the initial aneurysm occlusion rate is indicative of, and the literature bear this out as well, of a high rebleeding rate. Okay, so that's an important point, is that despite the low initial occlusion rates, even out to 6 months, many of those patients will continue to go on to occlude.
Okay, can I just make a comment? Yeah, it's unfortunate that there is nobody to defend microsurgery, but very great talk, Ahmad. Dr. Ahmad, it was a balanced talk. I appreciate that. But a couple of comments I would like to make. Number one, I wish I had given this debate rather than the robots, which I have no knowledge about. But anyway, so the number one is ISAT being, kind of taken out of context. ISAT was only small aneurysms, grade 1 to subarachnoid hemorrhage in anterior circulation. But it has been, taken to, it has been for all aneurysms, which is unfortunate. I mean, that did shift the paradigm shift, and that happened because of ISAT, because of wrong, interpretation, because it's only for very select group of aneurysms which are treated by ISAT, right? You would agree with that, number one. Number two, the 18-year follow-up which ISAT presented, the Moyamoya data which presented, is actually a 10-year follow-up. It's not 18-year. If you read correctly, it's a 10-year. You feel the whole. Very few. Obviously you have read it, but very few people read it. They read the title, they read the abstract. It's a 10-year follow-up. It's not an 18-year follow-up. Number two. Number three, the Barrow trial did not have a difference of 15%. If you see the 10-year data, there was no difference, in spite of the crossover of 37%. And that's a remarkable find. The conclusion rate was abysmally small. This is one of the best centers in the world we are talking of, right? So I think what has happened is industry obviously is there. There's no question about it. The patients are scared of open skull. If you cut us, you see okay, I'll do a pinhole, I'll do a needle, and that's it. Obviously, they will be agreeing to that, right? But I think there is over treatment of the aneurysms inappropriately by endovascular means. I have no question about it, because I see only those complications now. I don't see the primary subarachnoid hemorrhage. The GP send it to endovascular colleagues now. So
I'm sorry, guys. I have to end this discussion. There's another speaker that's been waiting, that has another talk to give.
Okay, right, fine.
So we have to.
So no further space for any comments?
No. Unfortunately, no. We have to move on because the next speaker has another talk to give.
Okay, sorry.
But you cannot leave the wrong impression.
Yes, just
I
only
feel that
wrong
I
impression.
presented a relatively balanced view. That's what I was trying to do, since I'm 50-50 on both sides. But and I think that is the correct overall view personally. I know that there's people that have very strong feelings about this, however.
I apologize for having to make us move on, but we're already way over.
Okay, thank you very much for a wonderful session, gentlemen. Lady, Karina, I just want to make sure Karina is acknowledged as well. Thank you very much.
Thank you, everyone, for another amazing session. Now, as Dr. Greggy said, we have to move on to our next session, which is the neurotrauma session, and I would like to ask Dr. Vandu Dawn and Dr. Ivana Rostova to please take over the floor and start the moderation of the session.
Good evening, colleagues. I'm Wan Duan from Xianwu Hospital, Beijing. It's my honor to co-chair this neurotrauma section with Professor Ivana. Now we are about 1 hour behind, so let's keep a time for a vibrant exchange. So first, let's introduce Professor Gregory, our keynote speaker, co-chair of BTF guidelines from USA. Greg, please.
Okay, guys, I'm going to have to move through this quickly. I'm needed to give another talk here in Milwaukee. Let's just imagine that we had a treatment that was developed for head injury, reduced mortality by 50%. I mean, that would be a dramatic advance, might even get you the Nobel Prize. And I think we forget sometimes in neurosurgery that we actually have a treatment like that, and that's the guidelines. The Brain Trauma Foundation guidelines have been consistently shown to reduce mortality from head injury by 50%. The most recent guideline project that we're about to publish, I'm pleased to tell you about today, that's a new guideline on penetrating brain injury. And it's a real shame, unfortunately, that this is such a badly needed guideline right now. The initial impetus for this, when I looked at different experts in the field, there were very different views on how to manage traumatic pseudoaneurysms. I figured that alone would be a very worthy topic to try and get consensus on. I think all of us in medicine, we're all on the side of humanity. War is terrible. But since we started this project, the need has further grown. And of course, violence in America is something that's an important problem in society. This is Dr. Surko in the Ukraine. I think all of us can agree that if a neurosurgeon needs a grenade launcher in his office, there's something really wrong with the world. So the way that the penetrating guidelines came about, so this is Dr. Randy Bell. So he was the head of neurosurgery at Walter Reed. When we started this, I just finished doing CBIC with Randy Chestnut. And he said, hey, Greg, CBIC was great, but I think we all sort of know how to treat head injury. Why don't we do this again, but for penetrating head injury, where there's way less guidance and way more diversity in care practices around the world? I also want to acknowledge that Dr. Bell lost his father to a penetrating head injury when he was 3 years old. I think it influenced him to go into neurosurgery, to go into the military, to become a world expert in penetrating head injury. So by completing this guideline, it a little bit rights this terrible wrong. To do this project, we pulled together about 35 experts from around the world, most of whom were actually active service military people who really have the world's top expertise in penetrating head injury. I think that all of us as neurosurgeons understand that these are really challenging cases for us, even those of us that are neurotrauma specialists. These are highly complex, but also highly emergent cases. They can be very distracting. Every patient's an N of 1. It's very common that these patients are so distracting they cause deviations from our standard ABCs and ATLS protocols. So we're really aiming here to give neurosurgeons a little bit more guidance to help improve the care of these patients. So here's our panel. We structured our guidelines into a section on pre-hospital emergency care, a section on surgery, a section on intensive care, and I'm going to show you a bunch of treatment algorithms that we're going to be publishing. We had the view that there was probably one best care for penetrating head injury, but we certainly were looking for any evidence that maybe perhaps military patients might be better treated in a different fashion than civilian patients, but in reality, we didn't really find that. Because of the criticism of our 4th edition adult coma guidelines that were viewed as being a little bit too legalese, we really endeavored here to bridge the gap between the evidence and the realities of care at the bedside. So we actually introduced or reintroduced expert opinion for the first time in about 20 years. So I don't have the time to go through the whole document, but I really wanted to highlight some of the key changes. So It's our belief that the real hallmark of a penetrating head injury is certainly the brain swelling, but it's much more so the complex neurovascular injuries that these patients can have. And so a combination of evidence and our expert opinion is that these neurovascular complications should be aggressively screened for early and repeatedly, treated aggressively. A lot of traumatic pseudoaneurysms can develop in a delayed fashion, so screening a second time between 7 and 21 days we think is very important. We think that the evidence and expert opinion supports the use of angiography over CTA in many instances. I was taught in neurosurgery school that you can't coil a traumatic pseudoaneurysm because there's really no wall. But people in the military and other people now have shown very clearly that these lesions can be coiled. And the benefit of coiling is that you can potentially preserve the parent artery and prevent a stroke. You need to recognize that these often need to be retreated. So we advocate repeat screening with an angiogram within about 8 weeks of the initial coiling. We're also recommending more selective use of antibiotics than in the past. And we don't have a lot of high-level evidence in neurosurgery. So the only level 1 evidence we have anywhere for head injury is not to give steroids. We had enough evidence in this guideline that achieving a watertight dural closure at all costs actually improves patient outcomes by reducing the risk of infection. So I think that's one of the hallmark tenets that's come out of this. Something that there really isn't evidence for, but something that's very clear when you talk to the US military. The military people say that they get better outcomes than in the civilian world despite higher caliber weaponry, and we think that's because they don't hesitate. They're very, very aggressive in their care, and that's probably the magic here. So I just wanted to highlight just 2 quick recommendations. It's all I have time for, but we don't think, even though prediction models, there's actually many of them. The spin score is probably the one that's best known. Although we do acknowledge they function well, we have great apprehension to see them used to, for instance, make withdrawal care decisions in individual patients. I want to highlight a bit of a debate that we had with reviewers. So our expert opinion was that we needed to try and encourage operations on people with penetrating head injury within 5 hours. I would certainly argue that this was not supported by strong data, but at peer review with the Joint Guidelines Review Committee, they basically forced us to remove that time deadline. I think as a neurotrauma field, we have to sort of talk about that issue. So again, the hallmark really of these injuries is the traumatic vascular injury. That's what we need to be probably more attentive to in the past. Recognize that we can probably now coil a lot of these lesions. We need to avoid nihilism. I just want to very briefly show you the algorithms that we've come up with. The big thing we're trying to do is we're trying to get the right resources and the right strategies into the right place. You have to sort of anticipate the problems ahead of time. We've tried to highlight some of the pitfalls that can happen if you aren't as prepared as you need to be. So the way that we've structured this, so all patients would pass down a master care pathway, but then we have a bunch of different toolkits that would apply to certain patients with certain problems. So we're advocating, obviously, an aggressive approach. And instead of trying to pick the patients that you think are going to do well, we're encouraging people to simply instead consider whether a treatment is going to benefit the patient or not, what we're terming a futility assessment. So we've got a toolkit for severe penetrating injury, traumatic vascular injury, protruding foreign bodies, skull base injury. I want to alert you to the fact that this will be published formally, coming out as a separate supplement in our Neurosurgery Red Journal in November. This document has been formally endorsed by Organized Neurosurgery. We're going to be releasing posters. There's a course, there's an app. We have a searchable guidelines program online. It's all going to be launched at the CNS meeting in October. Dr. Bell will be presenting this work as a plenary right before Spike Lee talks. Just very briefly, please also be on the lookout. We're very soon going to be releasing combat austere guidelines that provide guidance on how to care for head injury when you don't have a neurosurgeon, you don't have an ICU, you don't have a CAT scanner. We're doing a one-topic update on DVT prophylaxis. And Dr. Gajar is leading an effort to develop a new adaptable and rapid concussion screen. We're calling a rapid readiness screen. So please be on the lookout for these products all within the next half year or so. So with that, I have to go give my other talk. Thank you for this opportunity and best wishes, everyone.
Thank you so much, Professor Harlog. It was amazing talk. We know it's super hard to squeeze all the information to such a short time, but thank you for your insights of the topic for penetrating TBI. Because we are in such a hurry and we are in a short time, I would like to ask the next speaker, Dr. Alexander Jonsi from Germany. And can I ask you for your presentation? And the topic is chronic subdural hematoma management recent updates. Thank you so much.
Yeah, thank you. I hope everybody can hear me. Thank you for the invitation. Not a lot of time. This is a topic where we could talk a lot, but I just want to give you an overview of the standard management that we in our Department of Neurosurgery in Heidelberg University perform. This is based on the most possible evidence that we have. And obviously, chronic subdural hematoma is a topic where there's a lot of eminence as well. And I'm sure that many of the people who listen now have different opinions, but this is how we do it. And if you're interested, I can share this to anybody who wants to reread. So I imagine a patient coming into the ER, and this is the main question, GCS score below 15 and neurological deficits. If the patient goes into this category, we perform urgent surgery. If those symptoms are not present, we look at the imaging, and if there's certain imaging findings, maximum thickness below larger than 1 centimeter or the midline shift larger than 5 millimeter, we mostly in case of additional symptoms like headache, we also go towards surgery. When we do not see this kind of patient, we perform re-evaluation with additional CT scan. Looking at the images more closely before surgery, we have to identify whether or not acute components are present and whether or not those are significant. And then we can decide whether or not we want to perform mini craniotomy or burr hole trepanation. Some additional thoughts on this in our standard management procedure. We nowadays perform a frontal position burr hole in hemispheric hematomas, simply due to the reason that this creates the least central region associated complications when younger residents do it. Then otherwise positioning of the burr hole over or the craniotomy of the area of maximum thickness, and then normally we perform membrane opening, so membranotomy when we do any of those cases. Two very important steps during or after the surgery. One is repeated irrigation with body temperature solution. And then the other one would be we place a subdural drain, we leave it there for 24 hours. At heart level, patient can be mobilized directly after the surgery. Talking about antitropotic treatment, there's a couple of things that have to be taken into consideration for patients undergoing urgent surgery. Depending also on the lab results, we antagonize, so to speak, aspirin or clopidogrel with drugs in the OR, depending also on the bleeding. And then for patients on DOACs, for example, or vitamin K antagonists, we preoperatively use 4-factor PCC. If it's elective surgery, in urgent surgery, we pause the drugs. And if it's no surgery, we hold the drugs until reassessment and then decide. If the patient is operated and there's an indication for long-term antithrombotic treatment, that's something we usually try to assess with the cardiologists or vascular surgeons. Then there's a couple of questions to answer. Is this relevant? Yes, absolute. Then in this case, go there directly. We indeed nowadays perform MMA mobilization. If it's a relative indication, we hold antithrombotics for another 14 days, perform CT check, and then reevaluate. And if there's no indication, many patients don't really have an indication. If you ask closely, then we do elective clinical follow-up and CT scan only if the patient is symptomatic. So now this brings us to the last slide. When we do this kind of follow-up and we see that there's a symptomatic recurrence, generally spoken within 19 days, or even there's a second or third recurrence, we nowadays also bring the patients to MMA mobilization. This is the literature on which this is based, and this is my email address and Twitter handle. So if you want to get in touch, I have this flow chart that we are using, feel free to reach out. Thank you for your kind time.
Thanks, Alexander. Thank you for your wonderful speech. And then next, we'll introduce our third speaker, Dr. Piedad from Ecuador, will present TBI care experience in Ecuador. Piedad, are you here?
Thank you. Good morning, SIM colleagues. It's a true honor to be here with you today. Thank you for the invitation. I declared that I have no conflicts of interest, and I would like to extend my deepest gratitude to Professor Rubiano for his invaluable mentorship and for guiding the development and implementation of this project in Ecuador. Beyond one option for treatment of traumatic brain injury, a stratified protocol Bootstrap, by its English initials, is a structured clinical care model that guides the management of head trauma, providing stratified protocols adaptable to different resource levels and clinical settings. The goal is to reduce the variability in neurotrauma care, strengthen clinical decisions based on consensus of multidisciplinary experts by integrating scientific evidence. The Bootstrap protocol was first developed in Colombia in 2017, marking the beginning of a regional effort to improve TBI care across Latin America. For areas where established and continue until now, paramedics, emergency, neurosurgery, and intensive care, using Delphi methodology. Its formal publication in 2020 provided a validated roadmap for countries like Ecuador to adopt structured neurotrauma systems. The development of Bootstrap protocol followed a structured multi-phase process. The first phase is the preparation and subgroup organization. Phase 2, consensus building meeting, and phase 3, final consensus consolidation. In this phase are in Ecuador working in the consensus, in the consolidation. The final consolidation is based on these colors, and the color coding is intentional and intuitive. Green represents high resource settings, yellow indicates intermediate resource environments, and red reflects low resource context. Bootstrap has now been developed in Ecuador, in Paraguay, Brazil, and Peru. It makes and informs a growing regional network committing to improving neurotrauma care. These photos capture key moments from the Bootstrap implementation process in Ecuador, the inaugural session, the working tables organized by specialty, and finally, the consensus table where the national protocol was defined. During the consensus process, a key modification was made to the classification of traumatic brain injury severity based on the Glasgow Coma Scale, including 13 points in moderate TBI. We also realized the difference that here we have related with altitude and in relation with ventilatory parameters and even for arterial blood gas. With regard to fluid administration for resuscitation, we recommend the use of hypertonic solution at 4% because of the facility at the moment of the preparation. We established the use of tranexamic acid, hyperosmolar solution, glucose levels, and the treatment of seizures, also the analgesia and sedation. We recommend the use of whole trauma checklist and the criteria for transfer that are listed in the first protocol. In centers with resources for invasive or non-invasive ICP monitoring, we recommend to do it and also dictate the surgical indications for traumatic brain injuries and propose a definition for primary decompressive craniectomy. And remember that we are evaluating all the possible scenarios. So if you have neurosurgeon, but you don't have ICU, we suggest to perform early postoperative neurological examination and images studies. In centers with high resource, consider secondary cranial decompression if ICP is refractory to medical treatment under non-invasive or invasive neuromonitoring measures or biomarker index. In conclusion, the Bootstrap model represents a collaborative evidence-based effort to optimize traumatic brain injury care in diverse and resource variable settings. Its implementation across Latin America has proven to be a valuable tool for reducing gaps in care delivery, strengthening clinical capacities, and improving decision-making across all levels of the healthcare system. This protocol not only enhances clinical outcomes, but also fosters regional collaboration and adaptability, key elements in advancing neurotrauma care in our communities. Thank you.
Thank you so much, Dr. Piedad Acrio. It was great talk. Congratulations. We can maybe leave some questions in the end of the session, and if we have time. So we need to go on with the session. The next speaker I would like to invite is Dr. Davash Shukra from India. I hope I pronounced this name correctly, with the talk in near-infrared spectroscopy in brain trauma.
Dr. Davash Shukla is not here.
He's not here. So I think we can go on and continue with the next speaker, if he's here or she's here, Dr. Aderheim Haidara for Ivory Coast with the discussion. So we can continue.
No, he is not here as well. So you can discuss.
Okay, so we can discuss with these topics we had before. I would like to ask the speakers to unmute themselves. Dr. Yonsi from Germany and Dr. Acrio from Ecuador. I don't know, is Dr. Horlock from USA still available? Okay, I think I have a first question for Dr. Alexander Yonsi from Germany. I would like to ask you to some kind of conclude again about your post-op protocol you have in your country, because it's all the time is the discussion between acute suction of the subdural hematoma or passive suction after the evacuation. So, what's your insights of the topic?
Okay, I mean, as initially stated, so there's a lot of different strategies and unfortunately not so much evidence, although there are more and more relevant studies on this topic. For the drain topic overall, we stick to subdural drains, although there's some evidence for the subgallial drain as well, and we use passive suction, so this is no active suction. And the length of drainage has been reduced over the last year. So nowadays, evidence points to 24 hours being sufficient, and also mobilization really directly or early after the surgery. I mean, it's many times old patients, so it is other problems, but even more importantly, mobilization can be performed. And the bag is placed on the heart, fixed with a tape, and patients stand up. There is a risk of tumorcephalus, but with this kind of management, it is less than leaving the patient in the bed and then having them stand up maybe at night unobserved with the bag attached to the bed or something that creates more problems. And that's our experience.
Okay, thank you so much. I think it's pretty controversial, but in our country, maybe we're doing all the time subdural drain, and sometimes we use active suction on subdural drain, but you need to be very careful with management of the suction. Sometimes, that kind of like irritation of the dura or cortical force can occur, and we had some kind of experience with I think 2 or 3 patients with epileptic seizure, but I don't know if it's just because of the active suction or there was like actual irritation of the drainage on the cortical surface. So That's just our insights from our department.
In relation what you were mentioning, we had an experience with the subdural drainage, and we just move off, and the convulsions, the seizures stopped. So I think that the pressure that it can occur over the brain can lead to seizures also.
Definitely, yeah, and even more problems. But I mean, everybody has seen the brain plays into the central cortex. But I mean, what is a contra argument against the subgallial drain is that if you look at the evidence, you would need 2 burr holes, and usually we just perform 1 to make this effective. So, yeah.
What we made is a mini craniectomy temporal with both drainage, one directed to the frontal and the other one to occipital, and we have good results.
Okay, thank you. And may I ask you one more question about the post of CT? If you are doing, because Dr. Yonsi, you told us that you are doing only, or if I catch it like correctly, you're doing this the post of CT only in the patients if they are symptomatic or not. So what if the patient was symptomatic before the surgery and he's getting better, but still there is a deficit? Are you doing the CT scan also, or just skipping and waiting for the neurological improvement of the patient?
Yeah, I think there's very clear data on this that, I mean, this scenario you just pointed out, maybe not so clear, honestly, but for the, let's say, unsymptomatic patient postoperative, there's no need to do a routine CT scan. There's no benefit from that. And for this patient that you mentioned, we will also do no CT scan, because usually you will, I mean, that's now evidence, but usually you will not have a complete drainage of the hematoma with the technique that we are using with the drain, etc. And then you will be, you know, questioned by, obviously, by anybody. Do you have to reoperate? Can you make the patient better? Normally, if there is improvement, maybe not 100%, which is oftentimes difficult depending on the symptoms, this will not lead you anywhere. So the only reason we would do a CT scan is no improvement at all, or a worsening, or improvement and worsening. But again, I'm sure that other people will handle it differently here.
Thank you so much.
May I say something here? Tariq Khan from Peshawar.
Yes, Tariq.
Hi. So I thank you very much. So really very, very nice talks. And I completely agree with Alexander. I think if you do a CT scan immediately after doing a chronic subdural hematoma, you are going to be horrified at looking at it, because it will appear worse than what was the original one. So try and avoid doing CT scan as much as possible, unless really, really there is something. I think this is something for young neurosurgeons, this is something very, very important. Thank you.
Thank you so much. That's so true. And all the time, you know, the young neurosurgeons are so horrified that they did something wrong. So this is a good advice. Thank you so much. We have maybe...
Franco, you want to Franco wants to say something. Yes, Franco,
Yeah, no,
please.
well, my congratulations to Dr. Yonsi. I mean, your presentation is thoughtful. In the last year, 12 months, we had the publication of 3 randomized trials in acute chronic subdural hematoma. Let's say that until 2 years ago, chronic subdural hematoma was a dead body. Nobody wrote anything probably about drainage, but not that much. Now it's becoming a hot topic. 3 randomized studies, 11 review in 10 different journals in 12 months. So you understand that it seems to be the most important topic in neurosurgery, and everything is based on the new embolization technique. Your presentation, together with the consensus, European Consensus Conference, and what we are doing, which is exactly the same as you are doing, and in many other places in Europe, it is much more thoughtful. I mean, we cannot say that all over the world, every patient with a chronic subdural hematoma should be embolized. First, because we don't find someone to embolize. Second, because we have to centralize the patient. Thirdly, because of the cost. How much will it cost an embolization? And fourth, because still we don't have good evidence. So I'm asking you, how much did your practice change after this explosion of new technique and papers and randomized studies and so on?
Yeah, thank you. Excellent comment. And I have to fully agree. And I think that the explosion of interest in this is because now you can make money with it, and also because now neurologists and radiologists are onto it, and that really makes it explode. And if you look at where those RCTs have been presented, they've all been presented on neurological conferences. So again, something where we, the neurosurgeons, if you look at this like very strictly as a neurosurgeon, there is something that is maybe taken away from us. But I also see many colleagues that probably can do both. So that's excellent. So in our case, we are very privileged. We have a new radiology department in the university hospital, and we have access to this method, not by ourselves, but by colleagues 24/7. And they are very interested in doing it, again, because they can now make money with it. And they are on call anyway for all the strokes. So we have this has changed our practice. So we've implemented this. And for patients who probably would have operated a second, a third, a fourth time, and even very severe cases with anticoagulation problems where we would maybe have operated and we would have known that this is going to be problematic, depending on the severity of symptoms, we can use this now. And we have no evidence from our hospital, no data collected or published, but I think that, it helps. And given the data that is published by others, that's probably something you would agree. So yeah, it changed really our practice recently.
Thank you so much, Dr. Alexander. We have some question in the chat box, so maybe we have some time. We can.
Sorry, we need to move on because these people are waiting a long time.
Yeah, thank you, Professor. So we can continue with interview with the legend Franco Cervini. Can we continue, please?
So it's my absolute honor and pleasure to introduce Professor Franco Cervini, who I don't think really needs an introduction, but for some of the junior people, I might want to just kind of sum up. He's a true legend in the field of neurosurgery. He's from Italy, and he is a full professor of neurosurgery at Humanitas University in Milan, but he has honorary professorships all over the world. Russia, Argentina, Indonesia. He's been the past president of the World Federation of the Neurological Societies. And his interests are in neurotrauma, like with neurosurgical education, traumatic brain injury, global neurosurgery. He's prolific in terms of his academic and clinical contributions with an H index of over 48, over 9,000 citations. And he's had a really tremendous and profound impact on the field. In the last decade, he's been an invited speaker at over 72 international meetings, all in all 5 continents, and he's really, had an interest in teaching and training of young neurosurgeons. And so, I'm not going to waste any more time. I want to, give see if we can get Professor Cervini's incredible insight into some questions. And so I might want to start off with a few of the questions, because we did talk about guidelines. And I just thought you might want to give your perspective on some of the key elements on how, what you think of the present guidelines for neurotrauma care and what the future guidelines would be for practicing neurosurgeons.
Thank you, Eva. Even for the introduction. To be very short, because we only have 7 minutes for a couple of topics. We have been doing, our American colleagues, together with European help and other countries, South America and so on, have been producing guidelines in traumatic brain injury since '96. And the methodology is a very rigorous methodology, applying evidence-based medicine and stratifying the papers and the evidence for producing guidelines. The the system taught us a lot about how to deal with different papers, randomized studies, and so on. But now there is a problem all over the world. We have a global view of the process of neurotrauma. We all know that 3/4 of neurotrauma are in countries with limited facilities, and probably 30% of all worldwide workload for neurotrauma is done by neurosurgeons who have really limited resources, but they work. So the perspective now is to understand that we need good epidemiology, good data from centers where the resources are limited to understand how we can help them to cure our trauma patient. You have seen the bootstrap presentation before. The bootstrap presentation was stratified into different levels according to what you have, and what you can do is not only what you have available, but also what you can do, because you may have ICU available, but you may not have the monitorings, and it's not easy to say what you have or what you don't have, what you can use properly and what you cannot use properly. And the future of the guidelines is more and more having evidence-based medicine related to the fact that the end of the process is clinical utility for trauma patients, wherever they are. Because the concept of global neurosurgery is equity. We try to help the people to treat trauma wherever they are and however they can. And until now, we have been based on a very strict methodology, which is good, is a good starting point. But now we need to release more. We need to release let's say, we can call it stratified, we can call it adaptation, we can call it whatever you want. But we need a more global view of the neurotrauma process and how we can help the people who is in need. Eva,
So I'm going to switch gears a little bit and see if we can, one of the topics that haven't been covered here, but is something that's kind of being involved in a lot, are biomarkers. And what's your view of biomarkers and for triage and potentially outcome evaluation in traumatic brain injury?
Well, biomarkers, we have all seen the publication by the Jeff Manley group and the group working in biomarkers, the dedicated group, by inserting the biomarkers into the classification of traumatic brain injury, having clinical classification, as we have seen, the Glasgow Coma Scale, radiological classification, plus the biomarkers values to help in the decisions. I believe that we are at the point in which biomarkers, especially the two main, the GFP and the UCL, are now even being approved by FDA, and they are very helpful in decisions for trauma. I find it a bit, the whole literature about biomarkers is sometimes difficult to apply in our countries. In Europe, for instance, it's very difficult to substitute a biomarkers evaluation to a CT scan. As you know, Eva, it has been suggested that you can avoid a CT scan in mild injuries. This is very difficult because neurosurgeons intervene in the process very late, before the emergency physician already have done the CT scan, whatever you think and whatever you do. But the role of biomarkers is extremely important. When, for instance, mild injured patient is admitted to the hospital, and we have to decide whether or not to repeat a CT scan. in a mild patient with some few petechial contusions. And we always do CT, CT, CT. This is an important role. And the other role is in extreme condition. Very often in ICU, we are faced with life-saving procedures like decompression in patients that we actually do not know enough about this patient. Biomarkers in this patient can add information for the outcomes and help us for surgical decision. These, in my opinion, are two topics that we can develop more, obviously, together with the topics of using the biomarkers on admission to better our outcomes prediction.
So I know we're running out of time. I just thought I'm going to end up with the last question. I mean, you're such a legend. You've got a lot of young neurosurgeons on the line right now. What would be your kind of suggestions or advice for the young and up and coming neurosurgeons, and what should they be the take home with respect to neurotrauma?
I think the best advice, only one, is coming from the discussion we did before for chronic subdural hematoma. The first issue is understand where you are. Don't take passively randomized studies or guidelines dying for another completely different environment, but you should discuss and apply. And this is the most important. There are papers saying now that the standard of care for chronic subdural hematoma is embolization before doing anything. And it cannot be done. So people is frustrated and say, well, what should I do? I cannot do it. You should do what you can in your own country. And we have heard from Germany what they can do in Germany. We do the same in Italy. Maybe in Africa, it's completely not feasible. You know, that's the Barrow Institute published that embolizing aneurysm in Tanzania will mean destroying the economy for healthcare of the country. So we need to know where we are, and we need to contribute, work and published. This is important. We need to know what you're doing in trauma, especially.
Well, thank you very much. I don't know if we're going to be cut off. If we aren't, I have more questions, but
Salomon is the boss, so Salomon will tell us.
Listen, I can sit here for a long time, but obviously there are people waiting.
That's
but,
why
it's
I'm
fine
asking.
if it's good for young neurosurgeons. Yeah, why not?
One more. Go ahead.
Tariq,
it's
you guys to follow. So you tell us what you want us to do. You want us to have more chat?
Oh yeah, I think next to Franco is a treat. Maybe another question or two would not be bad.
Okay, so one more question, and because we're neurosurgeons, maybe you could discuss what you think about the surgical management of traumatic brain injury and spinal cord injury, because neurotrauma isn't just the brain. What you feel in terms of your perspectives and your key elements with respect to the surgical management of these injuries.
Well, we have touched a topic before when during the presentation of Greg and Yancy. Very important topic. And the bootstrap. When traveling around the world, we discovered that there is we divided decompression for trauma into primary and secondary, as you know, Eva, as we all know. But there is a third option, which is called preventive decompression, which makes sense in countries with very limited facilities. If you don't have a proper ICU, or you don't have enough bed in the ICU, or you cannot monitor your patient, the surgical prevention is the easiest one, and is the less costly. If you do it in US or in Italy, you made it wrong. So preventive decompression is not to be done in countries where you can monitor your patient, where you have time to decide, where you can decide which is the right time to do an hematoma evacuation and possibly a decompression. But in countries where you don't have this time and you don't have the resources, maybe the decompression is helpful. And the second issue are the new techniques, the new surgical techniques who can be done instead of decompression. One is the hinge craniectomy, raising up the bone, and the other one is also very discussed, the cysternotomy. Both techniques are under investigation. Decompression is proved that it works as a life-saving procedure. The other two, not yet. But we are working on this, and we are considering that the spectrum of surgery that we can do is enlarging, and this is important.
Well, thank you very much, and I want to be respectful for the other speakers and respectful for the time, and thank you so much for your insights and your knowledge. Very much appreciated.
Thank you. Thank you, Eva. Thank you, everyone.
Right. Thank you so much for that. And moving on to the global neurosurgery session, it is my honor to introduce Prof. Walt Johnson from the US and his keynote on stroke in developing countries and surgical treatment.
Good morning, everyone. I'm trying to get my slide deck to, can you see my slides?
Yes.
Okay. Excellent. Well, thank you for the opportunity to speak about strokes. It is one of the biggest causes for mortality around the world, even in the smallest countries. The burden of stroke is significant. 70% of strokes occur in low and middle income countries that bear almost 90% of the burden as far as disability adjusted life years and deaths.
Sorry,
could you just slideshow? Just press on slideshow on the top. Yeah, please. Or the bottom, wherever.
It says I'm screen sharing. You can't see these?
We can, but it's not slideshow. If you go to the bottom on the right.
There we go.
Yeah, thanks.
How's that? Is that better?
Perfect.
Good. Sorry. In poorer countries, incidence has more than doubled over the past several years, where it has dropped precipitously in high-income countries. The stroke is a different disease in poorer countries. It occurs 15 years of age younger in general, often during times of peak productivity. A much higher percentage are intracranial hemorrhages as opposed to the high-income countries. And of course, because of treatments and conditions in those countries, the case fatality rate is much, much higher. Also, imaging is a significant issue. These are few years old, these numbers, but there's about one CT scanner for every 3 million people in low-income countries versus way over 100 in most of the high-income countries. Primary prevention has totally failed because it has been non-existent in many countries. And what does exist is too little, too late. There's virtually no rehabilitation, and economically it causes catastrophic conditions for families. I mentioned that the stroke occurs at the peak time of income in younger people, and
Sorry, you're muted, Walt.
I don't know how that happened, sorry. So it takes two people out of the family that could be earning income for the family. And of course, there's political consequences. People that are running for office or hold high offices in countries are taken out by strokes, and it causes instability. This is a map for NCDs, non-communicable diseases, and you can see particularly in around the equatorial regions that poorer countries, the incidence of NCD mortality is much greater. So when I was working at WHO, I was asked to review this manuscript for WHO bulletin called Managing Acute Stroke in Low Resource Settings, which was really looking at if you're a physician in a small clinical setting in a poor country and someone comes in with acute neurologic event and all you have is a bottle of aspirin and a blood pressure cuff, what do? Do you give the aspirin? Do you anticoagulate? So it was an excellent article and I gave it a good review, but I started looking around WHO, what are we actually doing for stroke? And there was virtually nothing. So I wrote a very strong editorial, as any good neurosurgeon would do, which they made me tone down dramatically because they said it was much too strong. But what was happening at WHO is their technical package for cardiovascular disease was entitled HEARTS, which really annoyed me because, like, what happened to the brain? Other than a small pictogram on the cover, it doesn't even mention the brain at all. And so I said, well, if you're a doctor in a small clinical space in a poor country, you have someone with an acute neurologic event, sure, you're going to grab the book entitled Hearts to tell you what to do if you're not sure. I thought it was totally ridiculous that there was not more being done. So I suggested strongly to the Lancet, because of my work with them with the Lancet Commission on Global Surgery, that we needed a Lancet Commission on stroke, and particularly aimed at the developing world, which came out. It took a little bit longer due to COVID, but this was published in 2023. And basically, we're looking at 4 pillars of surveillance, prevention, what to do with an acute stroke, and then most importantly, rehabilitation. And we wanted to stratify this based on resources, just like TBI. What you can do in high-income countries can't be done realistically in poor countries. We wanted to deal with data, essential medicines, and appropriate surgical intervention. But what we found was that stroke mortality, by our estimation, would increase by 50%. And the DALYs, or disability adjusted life years, would also increase dramatically. And the costs would go up exponentially based on what is available to do and lost productivity in those countries. And clearly, the reduction of the global burden of stroke was imminently necessary, and particularly in poorer countries. So we recommended strongly establishment of framework to monitor stroke. Many poor countries have no idea the level of stroke in their country. So how do you make rational health policy when you have no data to drive that policy? So having a surveillance network of the level of incidence and prevalence of stroke would be very important. And then implement a population-wide prevention strategies. It's estimated, for example, in the country of Rwanda, 40% of the adult population are uncontrolled hypertensive. Well, that's not good when you're looking at cardiovascular risk prevention. So looking at making medicine available to people, do primary screening to be able to treat those people and prevent stroke in the first place is really important. And then acute stroke services, not only having aspirin available, but there's good evidence that having a stroke unit, even if it's a single bed or two, monitoring blood pressure, heart rate, et cetera, has great implications for outcomes. And these are not expensive to open. It takes a little bit of training for nurses and whatnot, but it's really a fairly simple way of reducing the impact of a stroke. Train people. There's great emphasis all over the world on catheterization, clot extraction, TPA example. And having stroke units, having cath labs, having things, these are all in demand around the world. And then an interdisciplinary stroke care service with neurologists and radiologists and neurosurgeons. And then, of course, having an advocacy system that can push politically to have these things done in that country. So we looked at primary or primordial prevention, looking at some of the things that drive cardiovascular risks, primary prevention, as I mentioned, and then secondary prevention. Once a stroke has occurred, how do you develop this polytherapy that will prevent extension? So I was asked to talk a little bit about the surgical treatment of stroke. And as you've already heard and you know, there's really three types of stroke that we are accustomed to. And neurosurgeons get called for TIAs and completed strokes. And angioplasty and stenting is a common thing to be done at many levels, not just carotid, but intracranially as well. You've seen clipping and coiling of aneurysms, a wonderful talk by Dr. Ahmed this morning. Those are routine things that are done, but economically, in poor countries, if a surgical clip costs $200 and coiling costs $15,000, most families will go for the craniotomy and the clipping just for economic reasons. And of course, for completed strokes, as we see on the CT scan, where there's a large amount of cerebral swelling or a large posterior fossa hemorrhage, these need to be taken care of surgically with decompressive craniectomies in the supratentorial stroke that are life-saving. They allow for expansion of the brain. There is less brain injury, actually, and people do much better with a decompressive craniectomy. There's also intralesional TPA. This is just one patient. We had a whole series. Give TPA for a few days, doesn't require surgical treatment, and the clots often just vanish over the course of a few days. And then, even though it fell out of favor for a while, ECIC bypass for ischemic brain is a really good option in selected cases that are screened well. The big trials that were done in the 90s just didn't screen patients very well, and so everybody was getting a bypass for very poor reasons. And then, of course, it wasn't very helpful. But there are selected cases where ECIC bypass is really fundamentally important. So the future is there was a talk a few minutes ago on the use of robotics and robotics for thrombectomy, as well as robotics for coiling embolic agents and whatnot. This is happening. I've seen a robot experiment or units where they're really pushing the envelope of what robots can do. At this moment, they still need humans to catheterize the artery. But once the artery is catheterized, the robot pretty much takes over and moves things around. It injects, it does thrombectomies. There's many different things. There's, as you've heard from previous talks, all the different gadgets, if I can be unprofessional enough to use that term, but all the different things that are being developed for the use in embolization and water, just remarkable. So the future for stroke care is still emerging, and there's a lot that can be done, but it's a global issue that needs to be addressed by all of us. And I thank you very much for this time.
And that's perfect. Thank you for ending your talk right on time. Next, I'd like to invite Ms. April Subangan, who's the CEO of Mission Brain, to deliver her talk on what global neurosurgery is and its importance.
Let me just set my slides up. Okay. Hi, everyone. Thank you for inviting me on behalf of Mission Brain. I'd like to thank Dr. Khan for giving us this opportunity. And I'm very excited to be able to talk about the focus of our organization and our part in the larger global neurosurgery community, rather. So there's a widely accepted definition of global neurosurgery. It is the practice of neurosurgery with the primary purpose of delivering timely, safe, and affordable neurosurgical care to all who need it. There are a few studies, I will say, as global neurosurgery is still a very young subspecialty in the global neurosurgery community. So approximately 23,300 neurosurgeons are still needed for more than 5 million essential neurosurgical cases, all of which are in low and middle income countries that go unmet each year. And there are about 29 countries, 14 territories, and 1 independent state with no neurosurgeons, according to another study. Hopefully, I think we are finally to make a little bit of a dent on those 29 countries, but we'll discuss that in the next following slides. So global neurosurgery really focuses on a few things here. Let's focus on equity, especially as the greatest needs come from countries that are poorly resourced. It's also taking on a public health approach, looking at systems and collaboration with different disciplines and different sectors. It's focusing on education and training as it's building workforce capacity. Research is the backbone for the global neurosurgery, just like any of the subspecialties, specifically because there is very little information really that addresses and looks at a lot of the factors that are part of the focus of global neurosurgery. There's broad community engagement. So we work with a lot of governments, other nonprofit organizations like ours, professional associations, and many different stakeholders. There's a very important focus on health system strengthening rather than just individual interventions or although we continue to address specific needs, we're looking at it more broadly from a health systems perspective. So Mission Brain is a nonprofit organization dedicated to providing neurosurgical expertise and resources to patients, caregivers, and healthcare providers in underserved areas worldwide. So this is one of our first primary goals as we started as an organization, and just we kept evolving as we saw the unmet needs throughout the world. It also aims to establish a network that connects healthcare professionals, scientists, students, and patients with the goal of advancing global neurosurgery and neuroscience and increasing access to underserved populations. It's focused on advancing global neurosurgery through collaboration, education, research, system strengthening, and advocacy, all of which are the focus of global neurosurgery. So you can say that Mission Brain is really trying to advance global neurosurgery as it is widely defined. We have a 3-pronged mission, treat, educate, and empower. So Mission Brain started in 2011. We first started with a traditional mission trip model that many other organizations have started with, working in a global health space. And then in about 2020, during the pandemic, like most everyone, we were not able to travel, and we started our web-based activities. Everyone lived virtually. So that's basically how we got more traction online as we all got connected virtually. We began our Mission Brain chapters around that same time period, and we started with 67 chapters. In 2023, our chapters increased to 89 chapters altogether worldwide, and we initiated our current 7 flagship programs, which I will discuss later, establishing mission-driven programs and system strengthening. Currently, Mission Brain has over 107 chapters in 28 countries. And we have 7 flagship programs, majority are fully established. As I've mentioned, we are primarily, obviously, all of us caregivers and healthcare professionals, and our goal is to provide care and treatment to patients that are not able to afford these care, and also to be able to partner with local partners who require mentorship and assistance in terms of infrastructure, including supplies and equipment. We are also aimed at education broadly defined in the sense that we have a bunch of programs geared towards education, research, and anything related to that. We also have under one umbrella, the empowerment programs umbrella with including our neurosurgical capacity building program that got started about a couple of years ago. And then we have our scholarships program under our empowerment programs. So this is one of our, I'm sharing this, I think we're very lucky to have some of our board members here actually today, and I think they have seen this yesterday when we had our board meeting at Mission Brain. So one of our biggest project right now is our capacity building project that we established and worked together with the Ministry of Health in Sierra Leone, the University of Sierra Leone Teaching Hospital Complex, along with a bunch of other collaborators and partners and stakeholders, some of whom I will mention later on. But we're very happy that we were able to launch that in May when we went there on a trip with some of our members of Mission Brain. Fairly recently, a few days ago, we were featured in an NPR article covering the story of Dr. Aliou Kamara, who is the single neurosurgeon or a single surgeon who is providing neurosurgical care in Sierra Leone right now. So Dr. Kamara is an orthopedic surgeon who was doing some basic at a time, but these are some of our collaborators, and we really have been able to focus on some of these key aspects of global neurosurgery. Collaboration and systems approach are key. I've mentioned some of our collaborators. Dr. Walt Johnson have been in some of our meetings and even carried some of the instruments that Dr. Khan had provided. Dr. Key Park's also been a really important collaborator for our organization. So I will go over some of these really quickly. These are some of our programs. If you would like to reach out and learn more about Mission Brain, we'd be happy to. Our goal really, I think we all come from we started an ethos of give a man a fish and you feed him for a day, and teach a man to fish and you feed him for a lifetime. But what we're trying to say now is really to change the water. A paradigm shift, a breaking down barriers and systems thinking approach, re-examining traditional approaches, and gatekeepers, and radical change through transformational partnerships and collaboration, shared leadership and opportunities. So thank you all so much, and thank you for this opportunity.
All right, thank you so much. I would like to invite our next speaker, Dr. Ebenezer Trist from Ethiopia, to talk about neurotube defects and role of neurosurgeons.
Thank you very much. I would like to thank the conference organizers for the kind invitation. So I will be talking about another relevant global neurosurgery topics, neural tube defects. So neural tube is formed through the process of neurulation, and which involves the primary neurulations, which is responsible for formation of the brain and most part of the spinal cord, and the secondary neurulation, which is responsible for the formation of the distal part of the spinal cord. And depending on the time of the closure defect, so we have different type of neural tube defects, the commonest being anencephaly, encephalocele, and spina bifida. Most of them are a primary neurulation defect, and we see quite commonly children with myelomeningocele, open closed spinal bifida occultus, and encephaloceles in our setups. When we see the prevalence globally, different reports and systemic reviews have showed the prevalence varies globally, and high-income countries repeatedly have reported that they have there is lower prevalence in high-income countries mainly due to improved primary and secondary prevention programs. But a global systemic review showed the prevalence vary from 9 to 22 per 1,000 births, and the burden of the problem is more common in low-income countries, especially in sub-Saharan Africa. And different studies from Ethiopia, hospital-based studies, has showed a prevalence between 32 to 128 per 10,000 deliveries. And in our studies, using a prenatal ultrasound examination for pregnant women in Addis, we have found a prevalence around 166 per 10,000 pregnancies. And in our study population, the prevalence of spina bifida was particularly high. So it was around 122 per 10,000 pregnancies. So when we see the causes and risk factors, so neural tube defect has a complex etiology that involves both environmental and genetic component, and usually this element act synergistically and result in failure of the neural tube closure and abnormal embryonic phenotypes. And individually, each component may not be strong enough to impair the neural tube closures. And there are reports have showed different maternal, environmental, genetic factors which are attributed for the development of neural tube defects. And in our study, we have found out that maternal age above 30s and serum vitamin status, socioeconomic status, and presence of previous spontaneous abortion is associated strongly with a neural tube defect in our study populations. So when we see the treatment options consists of providing comprehensive and early multidisciplinary care, and it is very important for the good outcomes of children affected with these problems. And surgery is one of the main modality of treatment, and most of the defect needs to be primarily treated by surgery. And prenatal repairs is being practiced in few centers globally, and it has been reported that it's associated with an improved neurocognitive, neurobehavioral outcomes. And MEMS trial also have showed that the need for subsequent shunting is less in children who are treated prenatally, and they have better motor outcomes in long-term follow-ups. What is practiced in most centers globally is postnatal closures, and it's advised to have early postnatal closures. And the standard closure technique includes multi-layer closure techniques, and when needed, appropriate skin closures using flap may be needed, and sometimes spine reconstructive surgery may be needed together with the closure of the defects. So when we see the role of neurosurgeons in managing neural tube defects, one is the expertise in the surgical intervention, which is one of the main modality of treatment, and the other is as being a member of the team, the multidisciplinary team, which is responsible to treat these children with neural tube defect. And the other is children usually need a lifelong follow-up and care, so neurosurgeons have a role in the longitudinal care of these children with neural tube defect. And the other important component in the management of neural tube defect is the prevention, and this includes the primary and secondary preventions and adequate micronutrient intakes and adequate folic acid supplementation are very important. And prenatal diagnosis, especially in resource-limited setups, are very important. And obstetric ultrasound, proper obstetric ultrasound, improved obstetrics care, and biomarkers like serum or amniotic fluid alpha fetoprotein and acetylcholinesterase are important for predicting pregnancies affected with neural tube defects. When we see the advocacy and educations, neurosurgeons as a public health advocates, they need to educate the communities and policymakers, and they need to promote the importance of prevention, and this is very important. And the role in reducing inequities in care access is also needs to be improved. And in the futures, increase public awareness about the problem, the risk factors, and prevention has to continue to improve, and socioeconomic and food security status has to improve, and adequate folate supplementation, fortification, multivitamin fortifications are important, and developing a multidisciplinary standard of care and implementing it globally is very important, and innovations in improving prenatal cares, including detection in resource-limited setups and access to advanced treatment options like prenatal surgery is very important, and ongoing, like continued research in identifying specific risk factor in a specific community, especially in higher prevalent communities, is very important. And neural tube defect present a significant challenge that varies across different regions, and high-income countries have made significant stride in the prevention and treatment outcomes, while still much work need to be done globally to improve the outcomes. And role of neurosurgeon is significant in improving the prevention and outcomes of affected individuals, and it's essential that we continue to push for better access to healthcare and public awareness, and support an ongoing research to reduce the global burden of neural tube defect. Thank you very much, and please take a few minutes to scan this barcode and register for African pediatric neurosurgery section. So this has been this is an initiative to improve pediatric neurosurgery in Africa, and we are doing this with the leadership of colleagues, professors Padiachi from South Africa, Mohammed from Egypt, Teddy from Ghana, and James from Nigeria. Thank you very much.
Thank you so much, Professor Beneza. We now move forward to another topic of epilepsy surgery, which will be presented by Professor Igor Trifinov. Please welcome.
Hello, dear colleagues. Is everything okay?
Yes, please. I can see your slide. Please go.
Yes. Yes. Okay. Thank you. Thank you for organized committee. Thank you. Big thanks and salam to Professor Tariq Khan. I will talk about epilepsy surgery and how to begin epilepsy surgery. There four core domains of training is to look for the patient for diagnosis. Next step is counseling. Next step, the big step, is pre-surgical evaluation of the patient, and only after it, it's the surgery. What we need? We need a multidisciplinary team, where is a neurologist, epileptologist, neurosurgeon, neurophysiologist, neuropathologist. It's I think, ideal world where the neurosurgeon is in a clinic, and the epileptologist will send the patient with the, for example, DNT of left temporal lobe with scalp video AG, and the epileptologist will send the patient to the neurosurgeon for the, for example, left anterior temporal lobe surgery. It's the ideal world. But in our world, that all these evaluations, for example, of mandatory studies, for example, for brain MRI in epilepsy protocol, video AG monitoring with size detection, neurophysiological evaluation, and the next steps, for example, invasive AG, will need to do for the neurosurgeon. What should, if you want to begin this program in your country, you should, for example, you are a neurosurgeon, you are a young neurosurgeon, you should understand what is AG, how the AG is working. For example, to understand this seizures, for example, it's the seizure named that chapeau de gendarme of the onset zone in the left is the right temporal lobe, and is also the seizure of the patient. What you need to study the next is the invasive AG monitoring, to use the depth electrodes, to use the different, for example, mapping. For example, this is the tumor of left frontal lobe, and we put the electrodes, and in the clinic we begin to study where the functional zones are. The next step is the neurosurgeon need to understand what is PNES, psychogenic non-epileptic seizures, because it's look like a seizure, but it's not the seizure, because on the scalp video AG you can see that not no any discharges. The next step, you need to understand MRI. What is MRI? Different types of MRI, DTI, tractography, FA. The next step, you need to understand what is MEC and how could the MEC help you during the pre-surgical evaluation. The next step, the neurosurgeon, the young neurosurgeon, should work in the cadaver laboratory. The first step is to make the anterior medial temporal lobe resection with help other colleagues. And the next step, you will do the surgery, for example, anterior medial temporal lobe surgery with help of the VR, with help of neuronavigation system. It looks like we resect the neocortical first, and then the hippocampus and other structures. For example, this is the patient with the onset zone of the left hippocampus, but the patient is the doctor. We put the electrodes, and during the stimulation, we saw that the patient will have, if we resect the hippocampus, have the disturbances. So we made only temporal lobotomy, and after this, patient is seizure-free. Next, you will do the different types of the wake surgery. For example, is the patient with the focal cortical dysplasia of left parietal lobe, and you do the wake surgery. Next step is VNS, when you couldn't do any surgery, for example, for patient with generalized epilepsy, or the patient after failed resective surgery. Thank you for your attention.
Right. Thank you very much. And that ended well ahead of time. We have about 2 minutes left for any questions, or we can move on to the group discussion with our previous speakers as well.
I try to be in time because it's better to answer the questions if you have.
Yeah, if I ask you a question, Professor Igo.
Yep.
In LMIC, actually multidisciplinary collaboration, that's a big issue based on the fact that there's too much workload. Neurology, they are so busy attending so many cases, neurosurgeons likewise. And you find that epilepsy cases, they end up getting medications throughout their lifetime until they get psychosis and mental disorders. I'm wondering what will be the easiest way of bringing up surgical epilepsy cases on the table to
Thank you.
neurosurgeons. Most of the
Yes.
cases are attended by neurologists.
Yes, but you need, for example, to look for patients to tell them. It's like you begin to work with the patient, one patient, and he will talk to other patients that epilepsy surgery could survive their lives, could be seizure-free. And also you with the work with the multidisciplinary team only. and with the psychiatrists to help you with these cases with mental disorders. You couldn't do, unfortunately, for only yourself but you will be the first who will talk to your colleagues to make this surgery, to try to treat these patients, to help their lives.
Thank you.
I believe public awareness. So sorry. I believe public awareness, even in epilepsy, is important, that patients and doctors should understand that there is treatments other than medical treatment, because some patients may have, especially intractable epilepsy, may need surgical intervention, and a lot of doctors and patients, of course, they do not know about this. Thank you.
Thank you, Tark. Thank you.
And I think we have time for one more question, if there's any from the general audience.
I'd like to ask Dr. Trifonov, excellent talk. Is there any role for simulation training in learning medial temporal lobectomy?
Yeah, excuse me, what?
Is there any simulation training available for medial temporal lobectomy rather than just a cadaver lab? Because that's not available in every country.
Yes, I think the simulation, it's very hard to answer, because the better work for neurosurgeon is to work with the patient and also with the cadavers. For example, in my experience, I began this work in the emergency neurosurgery, when you begin to have surgeries during the TBI, or maybe different temporal lobe hematomas, and you can try this surgery for next epilepsy surgery. Because, for example, in our country, we begin our work from the emergency surgery.
And thank you. We move on to the general discussion with our previous speaker, and we're also joined by Dr. Gail Rousseau and Professor Tarek Khan as well for the general discussion. Seeing as there aren't any questions in the audience for now, I had a general question to the panel. To start off, there's been previously mentioned about the importance of research, especially when sort of collecting data and highlighting the initial problems. In terms of how neurosurgeons from higher income countries can meaningfully contribute to this in this area, what would you say are sort of the main barriers, and how can someone in sort of with the lower middle income countries contribute to the development of research in lower middle income countries in a meaningful way?
Chloe, to whom are you addressing that question?
I guess to the general panel, but if we could start with you, Dr. Rousseau.
Okay, thank you. Well, first of all, I didn't just join because I've been on for about an hour and a half. It's a great, really a great session, great seminar, webinar, and I congratulate everyone who's been involved with it. Really a step forward, so thank you. In terms of how people, I think you're asking about younger neurosurgeons and how they can contribute to the literature. I would encourage everyone, whether young or old or in between, whether from a high or a lower middle income country, to think about our work as being clinical scientists and trying to make sure that everything we do and all of the human suffering for which we have a front row seat leads to, at a very minimum, relief of that suffering, and hopefully also some clues as to how to prevent it or better deal with it in the future. So whether you're dealing with the patient as a clinical problem or whether you're looking at a systems problem wherever you are, I would encourage you to work with others, both locally, and now it's so easy internationally, to try to document and then find solutions to the common problems we all face.
Yes, I think the young neurosurgeons need to be encouraged, and I must say that a lot have been done. We have now a global section in the Red Journal in Neurosurgery. Gail Russo is the editor, and I would encourage everybody to try and send their research there. Also, you may know that the WFNS journal has got a global health section now as well. I'm the editor of that. You may want to be able to send there. And we all, both the Red Journal and the WFNS journal, encourage people, young neurosurgeons from lower middle income countries to send in. And there is now a way to be able to help them, to mentor them, Gail, am I right, in improving their English or improving the structure of the paper. Maybe you want to elaborate on that, Gail.
Well, yes, there is, although AI has gotten so good at language editing that I don't know how long that system will last. But World Neurosurgery is planning to add a section that will be voices from global surgery around the world. And the good news for those who are on a budget, which is all of us, is that there will be no publishing fees for that. And I want to assure everyone who is just getting started in the business of neurosurgical or peer-reviewed publishing that those of us who have a seat at the table are working very hard to change the system so that there will not be a need to pay for open access publishing. We haven't solved that yet, but we're working in that direction. It's very important from an equity point of view that doing and publishing research not be something that from which clinicians are excluded because of costs. Thanks, Tarek.
I think April has her hand up.
Yep, if I may add, thank you very much, Tariq. We also have at Mission Brain, it's our second year now, we have our research peer mentorship program that has been quite successful. This is our second cohort and we've doubled the number of teams that we have. So this is specifically geared towards those beginning scientists and those who have very limited resources in terms of having research skills. And they're partnered with mentors from all over the world and also with faculty advisors from all over the world. So this is open to those who want to apply. We also have a global neurosurgery research group at Mission Brain that's focused on trying to do quality research, higher level research focused on global neurosurgery that is used as a backbone in terms of some of our programming, implementation, science, part of that.
Just to finish, I must add that please everybody should know that global surgery is the heart of neurosurgery now, and everybody must be part of global neurosurgery. I think it's very important. Thank you.
Thank you so much, and that was a good message to end on. I now pass the floor to Dr. Surath Munasingh to interview Dr. Gail Russo.
Thank you. Hello, everyone. So it's a great honor and a privilege to have the company of Professor Gail Russo today for the discussion. So Gail needs no introduction when it comes to global neurosurgery. We all know her. So just to introduce her, and without getting much time, so we can go direct to the discussion. So she's a clinical professor of neurosurgery at George Washington University School of Medicine, USA. So she's a leading advocate for global neurosurgery, serving on the board of directors of G4 Alliance. And not to forget her contribution as a pioneer in women in neurosurgery, WFNS, YNS, YNS, etc., etc. So she is a true legend in neurosurgery. So welcome Professor Gail Russo for the discussion. We'll mainly consider Boston Declaration today.
Thank you.
So
Yes, I want to jump in just because you have the word legend in the title of this talk, and we're just 2 months past the demise of someone who really was a legend, Professor Ghazi Yazergil. And so I would like to talk about him just a little bit. I think it's important that we honor the true legend that he was, but it ties in with your question about the Boston Declaration. Now, many of you know that he passed away on June 10th. What you may not know is that I had the great pleasure of being one of the last neurosurgeons he was ever with. I had lunch with him on May 22nd at his home, at his invitation, and it ties into the Boston Declaration for this reason. As you know, he was 99 years old when he died, just shy of his 100th birthday. And as you may or may not know, he spent almost half of his career in the United States at the University of Little Rock. So the University of Little Rock was hosting in his centenary year a webinar in his honor. He did not attend. It was just a few months before he died, but he was present and heard my talk, in which I characterized him as a global neurosurgeon and as a disruptive innovator. Well, he really liked that characterization of himself, wrote to me, asked about the Boston Declaration, and in fact, asked if he could send a video to show his support of it, which he did. And we had it showing both in Boston and at the opening session of the WFNS meeting. And he was so interested in what we were doing in the Boston Declaration that he asked me if I would come to his home, have lunch, and tell him about it. And that's what we did on May 22nd. And our article about the things we learned in spending time with him that day is now a manuscript, hopefully being published soon in Neurosurgery, called Lunch with a Legend.
thank you very much, Gail. Thank you very much for reminding regarding Professor Ghazi Yazergil. So my first question is, stepping forward from the Bogota Declaration to Boston Declaration, which we consider as the global blueprint for neurosurgical equity, what are the key developments according to your vision when you compare both the declarations?
Right. Well, this is housed in the notion of equity, as you've said, and also personal responsibility of neurosurgery. We love this Latin phrase, we lead, and everywhere neurosurgeons live, we're able to be leaders. So we took this idea from the Bogota Declaration, which essentially said we have a professional responsibility to care about everyone who's trying to provide neurosurgical care, to saying what concrete things can we do. So the Boston Declaration is both a process and a series of pledges that culminated in April in Boston, where we had 3 international neurosurgical organizations coming together, and 500 people participated in a series of global online meetings that resulted in 100 pledges to improve global neurosurgery. These were all SMART pledges, specific, measurable, attainable. You know that mnemonic. So we are now working on the implementation of these 100 pledges that go everywhere from the pioneers of neuroscience nursing in Tanzania, who pledged to create a neuroscience nursing curriculum that is context specific for East Africa, all the way to a university that's pledged an $8 million neurosurgical wing for a hospital in Uganda. So this group is now meeting monthly under the leadership of Dr. Khan, and at the 1-year follow-up, which will be hosted in Tanzania by Dr. Hamisi Shabani here on this call. There will be a follow-up to see how we're doing in this neurosurgically driven implementation of 100 pledges toward improving access to global neurosurgery.
Great. Right. So moving on to young neurosurgeons. So this is the Young Neurosurgeons Forum. So what opportunities for young neurosurgeons in LMIC you got from the Bogota Declaration in terms of training and education?
Right. So in the Boston Declaration, we have these monthly meetings, and if you write to me or Dr. Khan, we'll make sure that you get onto the Zoom link so you can see what's happening. But when one has a group of really powerful pledges like this, we are developing infrastructure as we speak, a digital presence and so forth, in order to empower all the people that it takes to be able to deliver neurosurgical care. And it's not just neurosurgeons. Of course, it's being driven by neurosurgeons, but it's also neurosurgical nurses, administrators, this kind of neurosurgical ecosystem. We're taking responsibility for access to neurosurgical care around the world, and we deeply welcome young neurosurgeons to be part of this.
Thank you very much. Since the time is up, one last quick question from you. So finally, your comments on the future of global neurosurgery and the key areas or concerns to be developed. What do you think?
What are the key areas to be developed?
Yeah, to be developed, yeah, and concern.
One, I would say to broaden our coalition so that neurosurgeons, as important as we are in the delivery of neurosurgical care, every one of us knows we're not the only one who's important because we don't do operations alone. There are all kinds of people in this neurosurgical enterprise. And so we're referring to it as the neurosurgical ecosystem and bringing in all those people whose energies and genius are going to need to be part of the future. So we're broadening our tent, and we're also looking deeply into communications and technology to help us. So, for example, one of the silver linings of the pandemic has been that we can do something like this wonderful YNS webinar, where almost everywhere that neurosurgery is practiced, we now have the ability to communicate online. That's really important. And then the second thing is the really exciting new technologies like telesurgery, which will allow us to have ongoing psychomotor skills, surgical skills that one can maybe meet in an in-person session, but be able then to coach people throughout their surgical career by being able to observe in the operating room through telesurgery. So the bottom line, I think, is that global neurosurgery is extraordinarily bright in terms of its future and welcoming in terms of every young neurosurgeon being welcome. As Dr. Khan just said, it is a core responsibility, we believe now, to not only do the best you can for the patient in front of you, but to also, link hands and arms with those who are trying to provide that same care to others in their community. And so it's a very exciting world community of neurosurgery advocates that's being built. And I invite everyone who is part of this webinar to join us on this journey.
Thank you very much, Gail. Thank you very much for joining us today and for sharing your valuable perception, vision, and mission. Thanks a lot.
My pleasure. Great to be with you, Sarath.
Sorry, Walt, you want to say something?
No, I was just trying to send the clapping hands up for an excellent presentation by Dr. Gale. Thanks.
If allow me, Salman, to say something.
Sure.
Yeah, I think the Bogota Declaration started it, and then the Peshawar Declaration, and now the Boston Declaration really has connected so many people. And the most important thing, what Gail said, It's not only neurosurgeons, it's educates from all fields of life, whether they are nurses, whether they are technologists, whether they are educators like April, like so many people are part of that. And I believe the young neurosurgeons are the people who really need to be part of this and join everything. Thank you.
Yeah, we totally agree. I think young neurosurgeons have to be part of every specialty of neurosurgery and the areas where we are not covering very well. I think it's important. And what Franco said earlier and Tariq Khan said is, and Gail also hit the jackpot there, saying that we all need to help them nurture, grow, and with humility. I think that's important. And good to have Keenan back, who was flying to somewhere and is now back on. Good to have you. I think we move on because Professor Lama is waiting for an hour to tell us about WFNS Dubai and what feast we have over there.
Hello, everybody. It's my pleasure to be with you today here. I see lots of friends there. Hello, everyone. So I would like to welcome all of you to Dubai. As you know, these conferences are mainly for the young neurosurgeons, for them to learn and to get skills after that, and especially from the workshops. So please come to the beautiful city of Dubai, and let me show you a little bit about the workshops. So the conference will start with workshops in 2 days, the 30th of November and 1st of December, and then 4 days with the Congress. So on the first day, 30th of November, we have both hands-on workshops and courses. So the workshops are cervical spine workshop. Then we have the white matter dissection workshop, the full day workshop, microvascular bypass workshop, and then robotic spine surgery workshop. Then we have also the neuroendoscopy. And as you know, they will have a lot of, as you see, the program is almost ready here. It will be on the website very soon. Then we have the vascular carotid endarterectomy full day program. Then we have on the courses that we have in 30th will be a skull-based symposium, peripheral nerve course, the first part. Then we have neurotrauma course, the first part also, neuroanatomy course. And then we have the pediatric neurosurgery course by ISPN. And we go to the next day, the 1st of December, again, workshops, endoscopic spine surgery, spinal deformity, stereotactic and functional neurosurgery. Then we have exoscope and neurosurgery, the neurosurgical practice, which is something very new. Then the courses, again, the global neurosurgery symposium, which is very important now for all of us, skull-based symposium part 2, peripheral nerve course part 2, neuroanatomy course part 2, then also neurotrauma and pediatric neurosurgery course. And then at the evening, please don't miss it. At 8:30 p.m., we start with the opening ceremony and a welcome reception. We'll have very nice surprises there. So please be there. And then on 2nd of December, we start the Congress. And the Congress will start with breakfast symposium every day. Then will be keynote talks, coffee break, plenary sessions, luncheon symposium, then specialty breakdowns, breakaways, and then coffee breaks, abstract presentation. And on the first day of the Congress, we'll have the presidential dinner. And then on the third day, we'll have the faculty dinner. And it will be so on for all of the 4 days. And here I want to tell you about the visa. If you have any problem with visa, please write to us. Please write to Garant, and there is an email on the website. We'll try to help you the best we can to get the visa to the country. And really, it's not difficult. All visa information and requirements are all on the website. And then please notice that for speakers, any speaker, we have to get a clearance from the government. So there will be a security checkup for the speakers who need the passport and photo and a speaker bio at least 2 months before the Congress. And then so far we have 844 registrations. As you know, we had also reduced the fees especially for MICs. The fees was 100, and we will try our best to get more of these low prices in the coming days. Let's see, we'll try our best. So all the fees are on the website, and you'll see them there. And the venue is in the convention center. The good thing about the convention center is that everything is in the same plane. You don't need to go up or down to find the lecture halls. They're all close to each other in the same plane. And let me show you this video quickly. On this slide, I would just to tell you that Dubai is unique in a location. We have very good flight connection. So a third part of the world are just 4 hours away from Dubai by Fly Dubai airline. And the rest of the world are connected by Emirates. We have also Air Arabia, Al Ittihad, and Wizz. So it's really, really easy to get to Dubai by all these airlines. Thank you very much. And just quickly, I will show you the program and how it will look like, and it will be in the website very soon. So this is the preliminary program for the 30th and 1st of December. Then comes the Congress, and it will look like this. And we have, all the big speakers from all around the world will be there. So please don't miss it. You're all welcome. Thank you very much.
Thank you, Mohammed. I think excellent preparation, and we are delighted that you and Garant are looking after it, and I'm sure we will have a feast there. Now, one thing I want to make clear that there were 2,200 abstracts submitted for this Dubai meeting. Of those, 700 are selected for oral presentation and rest for poster presentation, and this all young neurosurgeons. There was special discount for lower middle income countries for 150 people that have already been availed. And we have requested the Administrative Council to kindly look into this and see if we can increase that further. And there's a meeting happening shortly in a couple of days where this would be discussed, and hopefully we should be able to get more people avail some discount. So that is about that. Now we are waiting for our quiz to start. For that, I'd request Deborah, as well as Sabino is already here. I don't see Deborah here. Where's Deborah? Yeah, there she is.
I'm here. I've been online for the last 2 hours.
Good, you learned something. Excellent.
Of course, yes. I always trying to learn, and you always provide me the opportunity to do so.
It's our pleasure. Okay, off you go, Sabino and Deborah.
Hello, Deborah.
Hi, Sabino.
I leave you the stage.
Oh, well, thank you so much.
Wait, Ahmad, can you just wait, please? Please, Deborah, do you know how this Kahoot works? You were here last time?
Not exactly. That's the first time for me. So I'll try to do my best. Imad more or less explained to me that I just have to introduce the questions, and then we will see what happens. I do hope that I'm not going to spoil everything here, as being a beginner.
No, if you want, you can participate. I'm just joking.
Unfortunately, Imad already mentioned that there is an age limit, and I am just above the age limit, just one or 2 years, no more than that.
Okay.
So
off you go. Yeah.
Yeah. So I think we should start having the questions now.
We have only 15 participants.
Why is everybody not participating? 133 people here. Can you please try? Did you say, yeah, the code is there?
Well, maybe somebody is shy.
Yeah, maybe.
Maybe we have shy people that don't want
visit
to
kahoot.it, then they have to input the code to join.
So people who haven't registered, please register, because it's important that you all play this. These are the questions from all the talks today, and some simple questions. There are only 20 questions to answer. I think we proceed whatever number we have.
Yeah. It might also be that okay.
Somebody's having trouble getting it.
Rossi says that they are having trouble entering the game. So there might be some technical problems, unfortunately.
Matt, can you check this, please, quickly? Please go to kahoot.it and then enter the game pin.
Yeah, the code is on the top of the screen, 895602, and there is also the QR code.
So there are 25 now.
Okay, so probably people are a little bit late in
26.
Joining us. Okay, so we can see that there is a progressive escalation of the numbers.
Mohammed, its link is right in front. It's kahoot.it.
So it's 32 now. Shall we start?
Yeah, I think so.
So, shall we?
Yeah, it's starting.
So there we go. So we start with this question. Chance of regrowth of the skull-base meningiomas after gamma knife surgery is? So the questions are none, 20%, less than 10%, more than 40%.
%100%.
Okay.
Second question. The D wave is particularly valuable during intramedullary spinal cord tumor resection because 50% decrease in amplitude is a strong predictor of permanent motor deficit, provides a specific assessment of the dorsal column function. It is easy. Sorry, I think we are going a little bit too fast. We didn't even finish the second question yet. Okay, so the third question is the most common complication after endoscopic third ventriculostomy in infants younger than 6 months is a basilar artery injury, a CSF leak, a stomach closure and restenosis, and a subdural hygroma. Sabino, maybe you could also step in and read some of the questions. Otherwise, it becomes a little bit monotonous with me.
No problem. There is a sound disturbing us. What is the main advantage on ube discectomy when compared to uniportal technique? Finer instruments, ability to use the microdiscectomy tools during discectomy procedure, better hydrodynamic aspect, the use of real bipolar.
It's already there, the answer, yeah.
Thank you. Okay.
Go with the next one, and then I step in again.
Okay, this is yours, Deborah.
What is the primary goal of the bootstrap protocol in the management of traumatic brain injury? To eliminate the need for imaging in low-resource settings, to promote early surgical intervention in all TBI cases, to provide evidence-based framework adaptable to varying resource levels, or to unify neurosurgical training across Latin America. Question number 6. Regarding infection risk following traumatic brain injury, which of the following are true? TBI patients face a higher infection risk than non-TBI trauma patients. TBI is not an independent risk factor for nosocomial infection. Elective neurosurgical patients have a higher infection risk than TBI patients. Timely antibiotics prevent infection-related mortality in TBI cases. Question number 7. In which group of surgery is intraoperative spinal cord monitoring most valuable? Cervical spondylotic myelopathy surgery, deformity surgery with severe correction osteotomies, surgery of patients with neurological deficits, spinal tumor surgery. Sabino, would you like to go with a question?
Yes, this should be question number 8, maybe, or yeah.
Yes, I think it's number 8, yes.
The next one is question number 8. So, what is one benefit of using artificial intelligence tools like ChatGPT in protocol writing? AI completely removes the need for supervision. AI can generate readable drafts in seconds. AI always provide 100% accurate references. AI can sign ethical approval forms. Okay.
Number 9.
Yeah, question number 9. Surveillance is not a significant component in efforts to reduce the incidence of stroke in any country. True or false? It's just simple. Okay,
So we are now halfway.
Yes.
Question number 10.
Which part of a manuscript should be written first? Methods, results and discussion, introduction, or abstract? Okay, Deborah, yours.
So question number 11, risk of meningioma treated by gamma knife turning into a malignant tumor is 5%, 20%, negligible, 10%. Number 12. What is one major limitation of AI I highlighted? It often produces identical vocabulary and style. It takes too long to generate drafts. It makes grammatical errors in English. It cannot give retrieval references.
Okay, 13, regarding immune function, which one of the following statements are false? Checkpoint inhibitors act as an immunostimulant. Ventilator-associated pneumonia is a common nosocomial infection. T cells are part of the innate immune response, and the cytokine GM-CSF expands the population of myeloid cells, exempli grazie a monocytes. This is very difficult. And the other one, which anatomical structure is most amenable to damage and complication where performing missed leaf surgery? Exciting nerve root, caudal pedicle, transversing nerve root, and central dura. Please, Deborah.
Number 15. MEPs and SPs lost in lower limbs post-correction, upper limbs unchanged. What is the first thing to assess? The depth of anesthesia, patient temperature, systemic blood pressure, and potential for spinal cord perfusion issues. The position of the upper limbs to rule out a peripheral nerve injury. I like this. Question number 16. Which of the following is the primary goal of epilepsy surgery? Cure all types of epilepsy, prevent future brain damage, reduce the frequency of seizures, cure the underlying neurological disorder. Sabino, your turn.
Yes. Question number 17. The next one. Which of the following is not a benefit of robotic surgery? Low cost, improved pedicle screw placement accuracy, less revisions and complications, or less radiation exposure for the staff? We are almost there. 18. What is the most important factor to determine the quality of AI output in medical writing? The formatting style applied, the speed of AI processing, the precision of the prompt, or the number of references used? Last two are yours, Deborah.
Okay. So 19, according to a study in 2024, how many countries, territories, and independent states do not have a neurosurgeon? 28, 14, 2, 29, 14, 1, 29, 13, 2, 28, 13, 1. And the last question, a major advantage of transcranial motor evoked potential over sensory evoked potential is their ability to monitor the anterior spinal cord, the corticospinal tracts directly, monitor spinal nerve root function with high specificity, provide a more stable and robust signal with less variability, be completely unaffected by inhalational anesthetic agents.
So I'm showing the results now.
So I think we should pay our congratulations to this podium of winners who have been able to go through the quiz very successfully. Maybe Professor Salman Sharif also would like to say a few words.
No, I think I'm grateful, both Sabino and Deborah, who did a great job, and all the young people who participated. Excellent. I think Marco and Keenan, who are here.
Yes.
Yeah. So if they're going to say a few words, and we have Imad, can you show us the book, the 3 books that we are giving to first, second, third?
Yes, sir.
And the abstract winners? Do we know the abstract winners, the oral presentation?
We like to see the winners. Who
Yeah,
they are.
exactly.
Can we see the winners, Imad? Is it possible to maybe get them to?
Yes, sir, here they are.
So first prize to Russia, Danny and Karsaj. But can we see them if they're here, please? Can we unmute them and also show their video?
Yes, sir. We did.
In the meantime, Marco, you want to say something?
Well, it was very, very nice afternoon. We saw a lot of presentation, and I think this is some innovation before Dubai, and I am very grateful to all the people that came here, and I listened very carefully the beautiful talk of Gay Rousseau, and I think we enjoy each other. We can discuss, you can speak. It's very nice. Thank you very much, Salman.
You're welcome. Keenan?
So I congratulate first Salman and his team and everybody who participated. This was a great symposium. I learned a lot, and I'm sure young neurosurgeons did too. I congratulate the winners. This is a great segue into going to Dubai, where we'll all meet and have a great meeting. I like the presentation of Professor Al-Alama, who presented a great program already, and a lot of people working on the program, but Dr. Borba, Dr. Salman, Dr. Zileli, and others have been putting a lot of efforts, including Dr. Al-Alama and all of us. So see you all there. And again, congratulations to young neurosurgery winners.
Excellent. If any of is Daniel, are you unmuted? Are you there?
I think I just admitted Daniel Encarnacion Santos to the room now. I think he should be probably online now.
He's a co-host, so it's okay. Are you there, Daniel?
He's here, but he's
Okay, no worries. Who got the second prize? These are oral presentation winners.
Yeah, Dr. Sairaj, but she's not here.
Okay, and then third.
Azad say he's here, but he's
Okay.
not. Yeah.
Good. So Luis.
Good evening, everybody.
Okay.
Good evening, everybody.
Good evening.
I want to say a very big thank you to my mentors and teachers. This presentation or this conference has been very enriching from the plethora of presentations that have been made, and I consider it a very rare privilege. And I know it has added in sharpening me to becoming a much, much better neurosurgeon. I wish and I long to attend several conferences in the future. Thank you, and thank you, and thank you.
Okay, Imad, is that it? So shall we move to closing?
Yes, sir.
Luis Baba, and do we have Mohammed Sabri here?
Yes, he is here.
Mohammed, if you are there, can you please open your video? Yeah.
Yes, I am here.
Okay, you want to say a few words before Luis, please?
Yeah, thank you. Dear colleagues and dear friends, it's a great honor to deliver the closing remarks. And as we bring this inspiring WFNS Young Neurosurgeons Neurotrauma Conference to a close, so I want to thank each of you for your energy, your comments, questions, and your contributions. And over the last 2 days and past sessions, we have not only shared our scientific knowledge and surgical techniques, videos, we have particularly built friendships, collaborations, and stronger global community for particularly young neurosurgeons. And our mission is very clear. We translate knowledge into better outcomes for our patients everywhere, in every region of the world. And it's not ending here, it's just a beginning. And when we return to our hospitals, our operating theaters, our teams, we carry with us the ideas and the inspiration we have gained through this valuable conference. So I thank the speakers, moderators, organizers, and of course, all of the participants for making this meeting so valuable, so special. So I wish you all continued success. The future of neurosurgery is in the hands of young neurosurgeons, especially, and also the giants and legends. So let's push the boundaries of our field together and shape the future of neurosurgery together. Thank you.
Thank you, Mohammed. Now we have the President-elect Luis Barba with us. Luis, please unmute.
First of all, I want to congratulate all the team that work and the leadership of Professor Salman and all his team. Imad that is working tireless, and his secretary, and Sabino that is stay 2 days here online.
But Imad was the best, Professor. Imad was the best because he did so many effort.
And when I was watching, I was a little bit disappointed with something, you see. Looks like the conference was not for the real people that was participating. But the time come, you see all the information that you have sent to this young neurosurgeon. World Federation must concentrate in the people that really need us. When you see the Global Neurosurgery Committee, the leadership of Professor Tariq Khan, the presence that the work Dr. Johnson, Gay Rousseau are doing many, many years in global neurosurgery. I think you have a lot to do it, but you are on the right track. You can help the people, you can help the young neurosurgery with education. What's the difference in neurosurgery in the rich country, in the poor country, that the World Federation can solve? Is education. You need to try to educate them in this kind of webinars makes the difference. The pandemic was the worst time to us, but gave this opportunity. Now you can have people from around the world. You can see all the information that you can get. the work that these people, especially in the global neurosurgery, they are trying to make the difference. But we need to use the international organizations like the World Health Organization to put our hand there. Dr. Johnson was there. Now our representatives, Professor Servadei. This way you can work directly in the country. I'll tell you something. I'm working here in Brazil, the Brazilian government, to help one country that's Portuguese speaking in Africa. The most difficult was not to get the money from the Brazilian government to this country. The most difficult was the country accept the way that should do. This is the World Health Organization in our participating there can help in you make the difference. But slowly you can go and improve. We're working now with some societies. The WFNS promised to us open their educational platform. I hope the European society also do the same, that education can spread worldwide. We need to educate. Education is the key for the development of the whole neurosurgery and the medicine in the whole world. Thank you, Salman. Thank you, all of you, for this wonderful webinar. And see you in Dubai or another place as soon as you go. Thank you.
Thank you.
Bye.
Thank you. Everybody, can you just switch on your cameras, please? Ahmad, can you allow everybody to switch on their cameras, please?
Yes, sir.
So we have a group photograph. Mehmet, you're already smiling. Ready? Greg is hiding. We can see your beard, Greg.
Greg is hiding his face.
Yeah, he would do that always. Don't worry about him. Okay, are we done?
Yes, sir. Thank you.
Thank you, everybody. I think, again, we had great time. And please remember, there'll be a couple more of these coming.